one of the residents
Yes,
will
sir.
be doing, sir. Sir.
Ramani madam, you can also send madam. Hello, Dr. Srinivasan. Good evening, sir. Good evening, sir.
Good evening, sir.
Good evening, Dr. Kanagavel, Dr. Shri Kumar.
Sir, good evening, sir.
Good evening.
Seeing you after a long time.
Yeah. Even Vimal sir has got DNB PG, sir.
Yeah.
Sir, they are also joining, sir. They are also joining, sir.
No, they can come forward to present, sir, because a lot of people are there.
Sir, anyone is welcome, sir. Anybody who is having a case can come, sir. There is
Yes,
no
sir.
restriction at all.
Yes, sir, we can tell that, sir, because so that everyone can. Sir, Vimal sir, you have DNB PGs. Ramani madam, you have PGs. Any case, madam. Good evening, Rajesh sir. Namaskar.
Rajiv, sir, good evening, sir.
Sir, namaskar, everyone, sir.
I
Ramani
think,
madam, you can ask your PGs also
Yes,
to present, madam.
Yes,
There
sir.
is no restriction, madam.
Yes, sir.
Repeated cases we are doing. Professor Kanagil sir, Ajay Khanna sir, everybody is there. We are repeatedly repeating it, madam.
Yes, sir. I will
So
see to it.
anybody is welcome, madam.
Yes.
Vimal sir, you are working with Santosh sir.
Good evening, sir. Yes, sir, very much. I have been working with them for the last 16 years or so. And Dr. Sri Kumar is also my teacher at Trivandrum Medical College. One thing I wanted to tell that it's quite useful for exam going as PGs as well as undergraduates, but it's not taken across most of the states. Probably we are representing in Kerala, so we can take it across. Any platform you are using it to advertise or?
Sir, we have a group, sir. Kanagil sir is there, Halstead's PG group that we have from Northeast India. Some PGs have joined, sir. So we put it there. Sir put it there every day. And
we'll inform you, sir. We'll inform you every week, sir. You can take care of it.
Yes, sir.
Probably every state there is somebody to put it in their state group.
Yes, sir. We are recommending everyone to do, sir. But the thing is, it is available in the YouTube, sir. So many people do watch over the other time also. We have close to 800 students watching every class, sir, within the week.
But if it is attended live, it sticks on to your memory more.
100%, sir. I am for live only. But then students also have various commitments, right, sir? So we give them the flexibility of joining.
Well, during COVID time, we had a very good attendance. We have 200 to 300 attendance. Now the COVID is over. Most people who have gone back to their routine work.
He repeatedly puts in WhatsApp, sir, and asks them to attend. But everybody is like, they would like to have only cooked food. They are not trained to cook. So they watch it in the YouTube, watch for 15 minutes, then switch it off and everything.
The examiners have become more disciplined and perfect in online media. The PGs have more of other liberties.
Yes, sir. Namaskar.
Sir, we can start. It's 8 o'clock.
Yes, sir. Hitesh and Arya, sir. Welcome, sir. Good evening, faculty. It is 2 minutes past 8. With the permission of the seniors here, Kanna sir, we have Hitesh and Arya, sir, Rajiv Sahai, sir, Srinivasan, sir, and other senior professors who have been invited today. Professor Shri Kumar, sir, from GMC Trivandrum. Professor Vimal Kumar Rai from Luz Hospital, Kochi. Professor Ishant from Atal Bihari Vajpayee Government Medical College, Bhopal. Professor Ramani ma'am from Guntur Medical College, Guntur. Professor Nishikant Pujar. Sir is from Al-Amin Medical College, Vijaypura. And we have 2 important cases kindly contributed by Professor Kanna sir, Dr. Shubham Kumar Gupta. He is going to discuss a case of varicose veins. And we have Dr. Preeti Vardhan from Government Tirunelveli Medical College, who is going to talk about a peripheral artery disease case. So, Shubham, are you with us?
Yes, sir. Good evening, sir.
Yeah, please, Shubham, please start sharing your PowerPoint. First, you introduce about yourself, your unit chief, and then your head of the department, and go ahead with your presentation.
Sir, am I audible, sir, clearly?
You are good to go, ma.
Slides are visible, sir?
Yes, please start.
Good evening, respected faculty members.
Go for the presentation, slide presentation mode. This editable mode.
Yes.
Go for.
Press F5, ma, full screen mode. Kana.
Yes, it's not F5.
You press F5, or you can go to down and Or you can go slideshow and make it a presentation type.
So it has.
Down there is, you have the volume button, isn't it? 50%.
Yes.
Next to that, there is one button. You press that one, sometimes it will work.
On the left to 50.
Not
I'm sharing.
for you.
Can you go to slideshow?
Yes. Is it, okay, sir?
On the top, you have view, insert, design, animation, slideshow, that plus the slideshow.
Yes.
Yes,
Yes.
from
Correct.
beginning, from beginning.
Okay,
Yes,
what was it?
you switch on your video, Dr. Shubham.
Sir, my video is on.
Yeah, you are good. You are good. Press that from beginning again.
Sir, actually, I pressed. It is full screen on my laptop, sir.
I don't know what is happening. Sir, other faculty, are you getting full screen
No,
or what?
we are getting only the editable mode.
You can increase the number so that it will be bigger.
Kana, there is one percentage, no? Next to the 50, round down bottom. You keep pressing the plus,
Make it more.
right down bottom.
Right down bottom 50%.
Yes, sir. Okay, sir. Sorry, sir.
Shubham, please
Got it.
unshare.
Yeah,
Yes,
Got
yes,
it,
yes.
sir. Got
yeah,
it.
that's good.
But that's an issue. That lower half of the slide only
Is it
visible.
okay, sir, now?
No, you see that all the full slide is visible.
Yeah, this is not.
You press F5, Kana. I could see Professor Manju Banerjee ma'am from West Bengal. Madam, please join us anytime, madam. Your PGs are welcome to give your case presentation. Most welcome.
F5.
Sir, let me share again, sir.
Yeah, please close it and share it again. You close it. Close it. Yes. Now you share again.
Meantime, I'm happy to inform that we have crossed 3,01,075 views as of now for our classes for the last 2 years. I dedicate this to all the teachers and the students who have been with us for the last 126 sessions of our Friday PG clinics. And then we are touching close to 10,000 members, subscribed members watching our program also. Thank you all the faculty who have been with this journey from the beginning. Thank you very much, sir. Thank you very much, everyone.
The credit goes to you basically.
Yes, sir. You are the captain.
You are the captain, man behind the show.
Sir, I'm
We are only.
All the Fridays, without a single Friday miss.
We are all visitors only.
Yes. I admit with all of you, sir.
Thank you very much, sir. Thank you, everyone. Thank you. Credits to everyone who has contributed, sir. 1 class, 2 class, multiple classes, all the classes. Shubham, I think I will allow the Preeti to present. You sorted your connectivity issues. Please unshare your screen, Shubham. We'll have next. Preeti, can you try sharing the your PowerPoint and start your presentation? Let Shubham start out. Shubham, I request you to shut down your computer and restart. Many times it starts out by itself. Preeti, are you with us?
Yes.
Make it full screen, Preeti. Switch on your video.
Yes, that's fine.
Please
Yes.
start.
Preeti, your video is.
Preeti Vardhan, are you there?
Preeti, remove your headset and mic, Preeti. Use your computer.
No, go to the settings, go for computer odd.
Today, sir was just now telling everybody has become savvy. I think today we are having an issue on this.
No,
Preeti, are you with us?
yes, sir, he is there. Preeti, go to the.
No, sir. I think he's not able to hear us, or we are unable to hear him. Preeti Vardhan, are you with us?
He is able to hear, sir. That's why he is.
No, he is using headset and mic, I guess, sir. That has to be removed. We warmly welcome Professor Pradeep Kumar Radhakrishnan, sir. Thank you, sir. Thank you for joining. Preeti, are you okay? We are unable to hear you, Preeti. I would request you to unshare, re-log in again.
You switch on the. Go to the settings, say the speaker. Remove your headphones. Remove the headphones. Speak into the mic and see. Test your speaker.
Sir, I think we will request him to unshare, sir. Let us not waste time. Preeti Vardhan, you please unshare your screen, Preeti. Sorry, faculty, for not training them in adequate time. Shubham, please go ahead with your presentation, Shubham. You go ahead with like this. You go to the next slide.
Visible now, sir?
Yeah, please start.
Yeah, now I think it is coming up. No. Go to the next slide.
Just click on the next slide.
Forget about it.
Sir, Srini sir.
Yes. Just click on
Srini
whenever
sir.
you're speaking the slide.
Srinivasan sir, I think
Sir,
you
it
have
is,
the
is it
PowerPoint,
full
sir.
screen?
Please share, sir.
1 minute, sir. I'll see.
Give me, you please unshare. I have a lot of disturbances because there are 2 bars which are blocking the view. Shubham, please unshare your screen. Please wait, stand by for Srinivasan sir to share. Yes, sir. We are able to see, sir.
Okay, sir.
Yes, sir. Can he start, sir?
Sri Kumar, sir.
Yeah.
Please start, Shubham.
So do I have to share the slide because I'm seeing the slides?
What happened, ma?
So just so I'm not able to change the slides.
You will not be able to change.
change.
Dr. Sir is sharing. You just read the slides. Srinivasan sir will handle the slides on your behalf.
You can ask for the next. Then he'll change it.
Good evening,
Listen,
respected
listen.
faculty members. Today, I, Dr. Shubham Kumar Gupta, second year resident from Institute of Medical Sciences, BHU, Varanasi, is going to present a case on varicose vein, and Professor A.K. Khanna sir will be moderating the session. Head of the department is Professor Puneet sir. My guide is Professor Sanjeev Kumar Gupta sir. So, 48 years old male, resident of Jaunpur, Uttar Pradesh. So, next slide, please. Is a revenue inspector by occupation, presented with chief complaint of. So can I have next slide?
You continue, ba?
So next slide, please, sir. Srinivasan, sir.
Yes, sir.
No,
Please
yes.
move the slide. Srinivasan, sir.
Next slide, please.
Sir, this was the first slide, sir.
Next slide, sir.
Listen, ba. You're not, sir, you're able to see my screen?
Yes, sir. Yeah, go next slide, sir, please. Slide number 2.
This is 2. This is 2. This is 1, sir. This is 2.
Sir, can you project 2?
This is 2, sir. This is 3.
It's changing, sir.
Sir, the slides are not moving, Srinivasan, sir.
Sir, move, sir.
Yes, sir.
No, I think there is some problem with the saving of the PowerPoint or something, sir, because the same thing he also had.
Wait, let me try. I can try. I can
Sir,
access.
you have a copy, sir?
I do have one.
Yes, sir. Yes, sir. Sir, Srinivasan, sir, try unsharing, sir. Let's try.
Okay, thank you.
I don't know whether PowerPoint is having an issue or Zoom is having an issue. Yes, sir. Paka. Go to the. Thank you so much, Ishan, sir. Thank you for taking all the pains of sharing.
No problem.
Shubham, I think you should go ahead.
Yeah, we can continue from here.
So, 48 years old male, resident of Jaunpur, Uttar Pradesh, revenue inspector by occupation, presented with chief complaints of dilated tortuous veins on inner aspect of left lower limb for past 3 years, heaviness in the left lower limb for 2 years, pigmentation of skin over left ankle for past 2 years, ulcer over inner aspect of left ankle for past 6 months. Patient was apparently asymptomatic 3 years back when he noticed dilated tortuous veins over inner aspect of left leg, which was gradually progressing up to lower thigh at present. These veins become more prominent at the later part of the day after prolonged standing and with heavy work, and reduced on lying down, lying supine. He complains of heaviness in the left leg for past 2 years, which is more towards the later part of the day and worsens on prolonged standing and heavy work. It gets gradually relieved on taking rest and as stated by the patient by putting pillows beneath the leg while sleeping at night. He also complains of dark pigmentation of skin over left ankle for past 2 years and painless ulcer over inner aspect of left ankle for past 6 months, which he attributes to a trivial trauma, gradually increasing in size, occasionally associated with cerebropurulent discharge. There is no history of bursting pain, swelling in the calf associated with fever, no history of intermittent claudication, no history suggestive of DVT. There is no similar complaint in the opposite limb or any abdominal complaints. He has no comorbidities and no surgical interventions in past. His personal history revealed mixed diet, history of cigarette smoking for past 5 years, 2 to 3 cigarettes per day. His bladder and bowel habits are regular and sleep cycle is normal, appetite is normal. There is no complaint of similar illness in family, any of the family members. For this illness, he, apart from regular dressing of ulcer and short course of antibiotics, did not have any other treatments. Summarizing my history, 40 years old male, revenue inspector, presented with complaint of dilated tortuous pain over inner aspect of left leg, extending up to lower thigh for last 3 years, associated with heaviness of left leg, which was more towards the end of the day for past 2 years, ulcer over inner aspect of left ankle for past 6 months, associated with dark pigmentation of surrounding skin. There is no complaint of, there is no similar complaint in opposite leg.
Shubham.
Yes,
Hello.
yes,
Shubham.
yes, sir.
Is audible?
Yes, sir. Yes, sir.
I want to add one point. Don't mention medical terminology in the history in presenting symptoms. Rather than mentioning dilated tortuous vein, you have to mention that there is a swelling on the inner aspect of the leg. Second point, don't mention ulcer. Ulcer is the medical terminology. Mention that it is wound.
Yes.
The history should always be there in the patient's own language. Patient's own language is very important for the history.
Sir, I think we can say ulcer, sir. Ulcer is allowed. Wound is different. Ulcer is different.
I think
We cannot say wound and ulcer. We cannot substitute wound for ulcer. Wound is,
I think it's a common terminology for uneducated people.
No, ulcer we can say that is allowed. allowed.
Patient doesn't know what is an ulcer.
Dr. Chaurasia,
something which is
most of the time senior examiner won't agree with this.
No, sir. In English, we can say as ulcer. That much is allowed.
I think
the history should always be in the patient's own language.
Sir, let me tell you, in local language also, in Gujarati we say chandu, and the English layman terminology is ulcer. So I think madam is right. We can say ulcer. That is acceptable.
Dr. Chaurasia, may I say something?
Yes, sir.
Actually, history is an interpretation, is a surgeon's interpretation of what the patient is saying. So I think these kind of speaking only in patient's language is usually, it used to be this thing, but not acceptable anymore. I mean, this is my take. In MRCS and FRCS also, they accept it. Accept it.
MRCS exam is different, sir, and our PG exam in our setup is different.
In MBBS, we tell them, but in PG, because he's a surgeon.
Actually,
I think,
yes, sir. Wound is traumatic disruption of the continuity in the lining epithelium, while ulcer is due to molecular depth of tissue. The discontinuity in the lining.
Let's proceed, please.
In wound, there is no molecular depth.
We don't want to waste much of time on it. The principle is patient's own language, but certain terms we can permit. For example, ulcer is a common terminology. Even for some educated patients may use ulcer. So it's not a purely scientific term. That's my take.
Okay.
Okay, Shubham, please.
Please, sir, continue.
Shubham, sir, can we discuss the history now? And
yes, please. Yes, please.
Yes, please go back.
What is your conclusion by your history?
Sir, from history, I'm moving forward toward, I'm keeping my clinical eye towards venous disease due to, sir, I cannot find any cause to it, so it is more going towards like a primary venous insufficiency.
Okay.
But again, I have to examine the patients.
Shubham, what are the summarize your history? Yes, to summarize your history. Just summarize.
I have a 40 years old male who is revenue collector by profession. So he has dilated tortuous veins in a respect of left lower lip. This is associated with a dark pigmentation. He also have heaviness, which is more towards the end of the day. There is ulcer, non-healing ulcer for last 6 months. So these points goes in favor of a venous etiology. At the same time, sir, I have elicited history to rule out, sir, deep vein thrombosis and to rule out, sir, arterial component and the neural component.
Shubham, you said it's a venous ulcer. From the history, what are the points in favor of venous ulcer? And yes. And what are the other conditions will you anticipate in this patient when you're moving to examination part? Will you consider any other possibility also?
Sir, apart from the long history, sir, patient has dilatation of the veins, and there is no history. He has only heaviness, sir. There is no history suggestive of intermittent claudication. So, kind of rules out, sir, arterial pathology. But again, I have to examine the patient further, sir. Apart from that, sir, there is an ulcer which is painless, sir, associated with dark pigmentation, sir. So these are all, again going in favor of, sir, venous ulcer, ulcer of venous origin, sir. Because in the arterial or in the other ulcers,
one more point is
do the venous ulcer is painless?
So not always, sir. Not always, sir.
So that's absence of pain is not a sign, not a symptom suggestive of venous ulcer.
Again, sir, I have to examine the ulcer, sir, to comment upon that.
See, the commonest symptom which you have said is the pain.
Yeah.
So your history should be elicited along with your most commonest symptom, which has been described in your summary as pain. So how will you describe the pain in the history? So how will you differentiate between the pain for an venous disease or it's an arterial disease or anything else?
Sir, I tried to clarify it with the patient. I asked the patient whether he has pain or heaviness. In here, the patient complains of bhari lagta hai, sir. So the patient complains of heaviness rather than pain, sir, at the later part of the day. It is more when he goes to work, sir. He's a revenue inspector, sir, and he has to work like 5 to 6 days per week. He has field work to do. Field work, sir, he has to stand for a long duration, inspecting everything.
You are saying that he's having a history of prolonged standing.
Yes, sir. History of prolonged standing, and sir,
it can be mentioned. There's a history of prolonged standing.
Classically mentioned in book.
Shubham? Sorry, sir.
Shubham?
Yes, sir.
How this heaviness type of pain is classically described in a book? What is the nature of pain in case of varicose veins? What is nature of pain in case of peripheral disease?
Sir, in the varicose vein, there can
rather than heaviness, it is a dragging pain in case of the varicose veins.
Yes, sir. Sir,
and in case of peripheral, it is cramp-like pain.
Yes, yes, sir. So,
can you differentiate arterial, venous, and neurogenic claudication?
Yes, ma'am. In the venous claudication, in the venous pain, ma'am, there can be various presentations. A patient can have heaviness, patient can have dull aching pain or dragging sensation. Patient can have, ma'am, patient can have night pain also. In which is but night pain is more. Night cramps are more common in arterial disease, ma'am. Again, there can be bursting pain if it is due to DVT, ma'am. Again, in the venous ulcer, in the venous etiology, the pain is more towards the end of the day. It is aggravated by prolonged standing and heavy work. It is not associated with walking. Like in arterial disease, the typical characteristic in which we describe the intermittent claudication is, ma'am, it is aggravated by, it is intermittent, it is cramp-like, it is reproducible, and ma'am, it is relieved on rest, usually in the early stage of the disease.
Neurogenic.
Ma'am, neurogenic, ma'am, it is not associated with walking and as itself. Ma'am, there is certain postures which patient takes and the pain gets relieved. Neurogenic pain is present even on the rest because it is because of the nerve compression.
Osteoarthritis pain?
Osteoarthritis, it is typically described as the patient puts his first leg forth to walk forward. The patient has pain.
Okay.
Neurogenic pain occur at the first step.
Yeah, yes, sir. Neurogenic pain occurs at first step, but
at the first step. No, and in case of claudication, there will be some claudication distance.
Yes, sir. Yes.
You mean to say in a venous claudication, you will not have a claudication distance?
Sir, claudication distance, sir. Sorry, sir. I have classically read it for.
See, how will you, man? The question asked to us: how will you differentiate the venous claudication and the arterial claudication? Both will occur only after some exercise.
Yes.
We do not talk about all your night pain. Everything is not talked as on the claudication. It is only for the deep vein thrombosis we get the claudication pain.
Yes.
And what is the point to differentiate whether this is a venous claudication? Apart from the characters of the pain, one is a bursting pain, cramping pain. It is very difficult for the patient to recognize that. But how will you ask the question to differentiate it is an arterial claudication from venous claudication?
Sir, venous claudication, sir, it typically, sir, reduces after limb elevation, sir, or sir, when the patient, but sir, arterial claudication, sir, patient has to take rest. Sir.
Patient will say something that there's some swelling in somewhere part which get released.
Yes, sir.
Something he will say.
Sir, ankle swelling, sir, ankle edema is common, which is more towards the end of the day. In the evening, once the patient, sir, wakes up in the morning, there is no edema, there is no pain.
In the evening?
But in the evening, as the day progresses, because of increased venous distension, sir, patient starts developing, sir, heaviness, pain, which is more towards the end of the day.
And after prolonged standing.
And after
prolonged standing.
Yes, sir.
And also he'll sometimes complain of itching as well.
Yes, sir. He complains of itching, but it was not present in my case.
So what do you mean by night pain and how it is relieved?
Sir, night cramps, sir, occurs because of, sir, it is seen in the advanced, sir, arterial diseases, sir. Sir, where patient complain, where
No,
patient has to...
night pain is very typical term used for the varicose vein, not night cramps. Night pain is for the pain which is occurs in the varicose vein. Patient after lying down, if you ask the history very promptly, patient will very clearly say he will always use to keep the foot against the bed and compress upon that, so that the foot pump will act. So these are a very characteristic pain. Don't confuse with night pain, venous claudication, arterial claudication. So the PG should be very clear cut in on that. Equally, rest pain. When you are talking about rest pain, it is entirely a different etiology. So a claudication pain is different, rest pain is different, night pain is different. So you must understand that and go ahead. You are mixing everything together. Go ahead.
Just now you mentioned one terminology, venous insufficiency. What does it mean? Venous insufficiency.
Sir, venous insufficiency is, sir, characteristically we call it, sir, in the CEAP classification, when it is C3 onwards, we call it venous insufficiency.
Proceed with the presentation. The time is moving, I think.
One last question. What are different types of venous thrombosis?
Different types of venous thrombosis. Sorry, sir.
There's something with deep vein thrombosis and superficial vein thrombosis, something related to that.
Sir,
it's a very pet question for a long case. Generally asked.
Commonly asked question.
Very pet question asked.
Sir is asking the pathology of DVT and pathology of superficial.
Something that not is known as phlebothrombosis or thrombophlebitis.
Yes, sir. So thrombophlebitis is seen in the superficial thrombophlebitis involves the superficial veins, and deep vein thrombosis involves the vein which are deep to deep fascia. Sir.
What is the commonest cause?
Sir, commonest cause of deep vein thrombosis. Sir?
Yes. Of thrombophlebitis.
Sir, thrombophlebitis, sir, commonly which we see is post cannulation, sir, post cannula insertion in the superficial veins. Patient develops
this is commonest cause.
Yeah, commonest, and second is the varicose veins.
Yes.
So we can move with the examination part now, I think.
The patient was examined in well-lit room with informed consent. Patient was conscious, well-oriented with time, place, and person, fairly built, well-nourished. He was affable at the time of the examination. Pulse was 88 beats per minute, regular, rhythmic, normovolemic. Blood pressure was 114 by 76 millimeter of mercury. Respiratory rate was 16 beats per 16 cycles per minute. Thoracoabdominal pattern. Patient weight 75 kg and height was 180 centimeters. BMI was 23.2 kilogram per meter square. On general survey, there was no pallor, icterus, cyanosis, clubbing, lymphadenopathy. Localized pedal edema was present in left limb around the ankles, and JPP was not raised. This is the clinical photograph, sir.
I think I'll ask one question before going to a local examination. Which is the most important general examination in a case of varicose veins, and why?
Sir, most important
general examination for a case of venous insufficiency. General in the general examination category. I'm not going to the local examination. There's only one single examination which is the most important for varicose veins, and why?
Sir, skin pigmentation, sir.
The examination of the abdomen.
Examination of the abdomen, sir, I have mentioned in the systemic examination.
It is the I asked which is the single most general examination in a case of varicose vein. That is the abdomen examination, and why?
So because that in one of the secondary causes of having varicose vein is presence of abdominal lump, sir, which compresses on the venous system and reduces the return, as a result of which there is venous distension and varicose vein disease.
And why? And what about in females?
Sir, in females, sir, in pregnancy there is compression of the veins. Sir,
which vein?
Sir, inferior vena cava, sir.
Or the external iliac?
Sir, external iliac, sir, usually the uterus, gravid uterus is tilted towards left side, sir. So there is left internal, left external iliac, sir, compression, as well as sir, inferior vena cava compression.
What will happen?
So the patient is, sorry, sir.
So what will happen?
So there is a decreased venous return, sir. So patient has sir pedal edema, and sir the patient might have some varicose veins.
Why varicose veins are more common in females?
Sir, it is sir in the so the hormonal effect on the veins, sir. Walls of the veins and the valve of the veins, sir.
Okay.
So there is a tone in the
which hormone?
Sorry, sir. Sir, progesterone.
What happens to progesterone?
What happens?
Sir, due to progesterone, sir, there are two effects, sir. One is, sir, the cusps become soft, sir, and the tonicity of the wall, sir, venous wall is somehow reduced.
The local examination.
Ma'am, the slides are changed. Actually, this was an old presentation, sir.
I have this only.
Sorry, sir. So on inspection, we can see there are dilated embossed tortuous vein involving the great saphenous system. So there are no dilated veins in the short saphenous system, sir. The localized swelling and pigmentation were noted around the ankle, sir. And there is no loss of hair, brittle nail, and dry skin or loss of subcutaneous fat. Next slide, please, sir. An oval shallow ulcer of 2 × 3 centimeter present over the medial malleolus, which is well defined with well-defined margins, the sloping edges, and plain granulation tissue present at the base of the ulcer, at the floor of the ulcer, sir. There is minimal seroperitoneal discharge. Surrounding skin is, sir, hyperpigmented, and there are reticular. There are thread veins, sir, present multiple around the ulcer, sir.
What is threaded vein, doctor? What is thread vein? What is reticular vein? What is ankle flare?
Sir, thread veins are, sir, less than 1 millimeter diameter intradermal veins, sir. Sir, the reticular veins are 1 to 3 millimeter.
Where will get the thread veins? Where will get the thread veins? Commonest site?
So thread veins, the commonest site is, sir, around the ankle, sir.
Okay, correct. Reticular veins?
So reticular veins are, sir, 1 to 3 millimeter in diameter, sir.
Okay.
And sir, varicose veins are, sir, more than 3 millimeter diameter, and these are varicose veins, sir.
What is ankle flare?
Sir, ankle flare is, sir, it is a
group of reticular veins.
Yes, sir. Sir, fanning out of
the medial malleolus.
Yes.
What is saphenous?
Sir, saphenous, it is the bulging of the. It is a bulge which is noted in the saphenofemoral junction.
Not bulge, it is saccular dilatation of the saphenofemoral junction. These are commonly asked definition in PG exam.
What is phlegmasia alba dolens and phlegmasia cerulea dolens?
Sir, phlegmasia cerulea dolens is painful blue limb, sir, and phlegmasia alba dolens is, sir, painful white limb. The pathology is whether or not the collaterals are blocked or not from most of them.
Why the pigmentation is confined to around ankle and the lower 1/3 of the leg?
Ma'am, in the venous diseases, it has been found that the greater area, which is this area, ma'am, it has. So, ma'am, the venous hypertension is more in the pressure is much more higher in this area, as a result of which there is development of these veins and pigmentation.
What is happening as
ma'am, the capillaries pressure increases, ma'am, because of which there is extravasation of the RBCs, and now the macrophages try to destroy these RBCs, and there is release of heme pigments, mostly hemosiderin, which gives the characteristic color.
Okay, what tests you have done?
Sorry, ma'am.
What clinical tests you have performed here?
Proceed with the
presentation.
You please finish the presentation.
On palpation, the local temperature was not raised. There was no tenderness along the veins or in the calf region. An oval ulcer of my inspector finding of the oval ulcer was confirmed, and the base of the ulcer was the underlying bone. The surrounding skin pigmentation, the surrounding skin was hyperpigmented, thickened, and indurated. All peripheral arterial pulsation was normal. There was no sensory or motor trigger deficit. The bilateral inguinal inguinal lymph nodes were null. The table shows various tests which I have performed. Brody's Treadle-Bug test 1 was positive, implying there was incompetent left SFJ. The second test was also positive, which revealed that the patient has incompetent perforators as well. Multiple tourniquet tests revealed the below knee perforators were incompetent. Modified Perthes test showed the deep veins were patent. Sir, Fagan's test was revealed multiple defects in the deep fascia in the leg region. Morris's cuff impulse test was positive, revealing that left SFJ was incompetent. On percussion, I performed the Schwartz test, which revealed that the SSJ was incompetent. Auscultation, there was no bruit or murmur heard. On per-abdominal examination, the abdomen was soft, non-tender. There was no dilated veins over the abdomen. There was no lump palpable. The systemic examination was within normal limit. Now, summarizing my case, 40 years old male, revenue inspector by profession, presented with dilated tortuous pain over inner aspect of left lower limb, extending up to lower thigh for last 3 years, associated with heaviness, which is more towards the end of the day, ulcer over the inner aspect of left ankle for past 6 months with dark pigmentation of surrounding skin. There are no complaints associated with opposite limb or abdomen. On examination, varicosities involving the left great saphenous vein with findings suggestive of incompetent, it was left SFG and incompetent below knee perforators, along with active venous ulcer and signs of chronic venous insufficiency. There is no evidence of DVT.
Shubham, I want to interrupt you. What you mentioned in Brody Tenderberg test type 2, you have mentioned that this is due for the testing perforators, incompetent perforators. But in clinical DAS, it is mentioned that it is to note the incompetency of the communicating systems, communicating veins, rather than in perforators. So how will you test the incompetency of the perforators? How so perforator is tested?
Multiple tourniquets tests.
Not by the Brody Tenderberg test. Brody Tenderberg test is for the communicating veins. Yes. In clinical DAS, it is clearly mentioned that it is for the communicating veins.
Yes. So communicating veins and perforators are same, no? Is it?
Both are
terminology is same.
Both are different.
So how will you elicit Brody Tenderberg test?
Sir, first of all, I will ask the patient to lie supine, sir. Then I will milk the veins to empty the superficial veins. Then I will tie tourniquet, sir, below the SFJ. Then in the test 1, sir, I will ask the patient to stand, and then I will open the tourniquet. If there is a rapid filling of veins, I will ask the patient to stand. I will not open the tourniquet. I will look for 2 to 3 minutes. If there is rapid filling of veins from above down, then it shows incompetent left SFJ. In the Treadle-Bug type 2, sir, after standing, I will repeat the same, sir. I will do the milking. I will tie the tourniquet, and after standing, I will open the tourniquet. And if there is filling from below upwards, sir, then it indicates incompetent perforators.
What is lipodermatosclerosis? Have you found this in this patient?
No, ma'am. This patient did not have had lipodermatosclerosis, ma'am. Lipodermatosclerosis, ma'am, is a finding which we see in the advanced venous insufficiency, ma'am, where there is soft fat loss along with there is sclerosis of the subcutaneous tissue, and the limb characters, the calf becomes typically hard like wooden calf.
No. Calf doesn't nothing to do with calf. It's only the skin and subcutaneous tissue. How is it in the area of pigmentation? Is the skin is supple or is it adherent to the underlying bone? Then if it is adherent, you call it there is sclerosis of the
Yes, ma'am. Yes.
skin and the subcutaneous
Yes,
tissue.
so there
that
is
is there.
typical
What
champagne
is this
glass bottle.
inverted champagne bottle appearance is all
Yes.
what you are saying. What is
Yes.
that inverted champagne bottle appearance and why?
Ma'am, ma'am, in the lower part of the leg, ma'am, there is a thinning of the skin and subcutaneous tissue, and it becomes adherent to the bone, which gives the neck of the bottle appearance. And in the above, ma'am, there is a thickening of the thickening and hardening of the skin and subcutaneous tissue, which gives the hypertrophy of the
it is not thickening and hardening. It is the hypertrophy of the muscle itself because of the chronic venous congestion there. That causes hypertrophy of the muscle over a period of time, which gives that bulkiness to the muscles.
Yes.
It is not any thickening of the skin. Here we are looking at the bulk of the muscle, right?
Yes.
Okay. What is your diagnosis? CEAP. Basing on CEAP,
my CEAP classification is C6. Etiology was primary, and A was anatomy was superficial as well as perforated. P was pathology was reflex.
Okay.
What is Pratt's test?
Those tests are all insignificant. Now
but
because
they are asked, they are asked, madam. They are still asked.
No,
PG level, they are still asked.
The duple is the test. These are all.
Yeah, but they are still asked, madam. They are still asked.
What the tests are? The
all the tests outdated, but they are still
test,
asked.
multiple tourniquet. These three tests are the most important tests that will tell you the site of varicose veins and the cause of varicose veins. Other tests are just passing information. But basically, the pathology is known by the color Doppler or duple test. Right? Okay. But you should know. Any examiner can ask fancy questions. So you should know.
In Pratt's test, we start tying the compressive bandage from below up, from the foot to groin region. This is done to do the milking of the vein. Then for emptying of the superficial vein, then we tie a tourniquet below the SFJ. And so then the compression bandage is removed and is now tied from above down, from the groin to the ankle, and we look for bursting out of the veins.
Okay.
Burst out appearance of the veins.
What are the complications of varicose veins?
Sir, varicose veins, sir, the complications include, sir, bleeding. There can be pigmentation, ulcer formation. Sir, there can be sir, lipodermatosclerosis, eczema, phlebitis, sir.
Anything can happen to the ulcer? Long-standing ulcer.
Long-standing ulcer has chances of converting into malignancy. That is nodular ulcer.
Suppose it is progressing to the back posterior aspect of the ankle, and what can happen?
When the patient develops an equinus deformity.
Then even squamous cell carcinoma, marginal ulcer, I have told. No?
Right.
Sometimes there can be a bleeding from a ulcer when it becomes very thin. It's not ulcer, the veins which get adherent to the skin. Trivial trauma can produce torrential bleeding. Then how will you manage this bleeding?
Ma'am, the bleeding is very profuse. Though the bleeding is very profuse, but we simply advise the patient to elevate the limb and put compression, and this in most of the cases.
Right.
Okay, Shubham, how will you manage? Okay, what will do the patient?
Sir, I would like to go forth with the investigation, sir. Sir, duplex scanning will be performed, sir. Along with it, I will do ABPI, sir. And
okay. For a duplex scan, you ask for a duplex scan. What are the points you need to need to know from the radiologist, or if you are doing it?
Sir, a duplex scan consists of two components, sir. Sir, in the first component, sir, we go for B scan, which looks for, sir, whether or not there, sir, the patency and the diameter of the sir veins, sir, deep system and the superficial.
What's why diameter of veins? What significance?
Sir, diameter of the veins are significant because whether or not this will respond to the usual, sir, compressive dressing and everything. Sir, compressive.
Pardon? Please repeat it.
Sir, the diameter is important, whether or not we will take the patient for surgical correction, sir. And sir,
how the diameter changes your surgical strategy?
Sir, whether the only SFJ ligation will be sufficient, sir, or we can go for, sir.
Okay, this patient diameter is 2 centimeter. What makes that difference?
No, sir. In this case, sir, there is ulcer, so we have to go for surgical corrections.
Okay, Doppler, you said you will ask for the diameter of the vessel vein. What is the significance of asking the diameter?
Sir, to call it varicose vein, sir, we measure, sir, mid-thigh diameter and, sir, below calf diameter.
No.
Sorry, sir, I'm not aware of that.
Anyway, you're committed that varicose vein. The importance of diameter is if the vessel is too large, it is not fit for doing an endovenous treatment. Okay, because you cannot compress the vessel, you cannot burn with the laser or radio frequency ablation. If it's a larger size vessel, more than 2 centimeter size, then ideally is open surgery still. If the vessel size is smaller, then that patient can be taken up for an endovenous therapy. That's the significance of knowing the diameter. Okay, that's one is the diameter. Then what all other points will you
in
get
the
from the radiologist?
doctoral study, sir? I would look for flow, sir. I would look for
which flow?
Sir, there are, sir, 4 flows: sir, spontaneous flow, phasic flow, augmented flow, and sir, compression flow.
Okay,
so these flows I will, and sir, then I will see the direction of flow, sir, and then apart from these two, sir, I will look for whether or not, sir, there is.
There
was a component, sir.
Most important thing you have to look for in Doppler, which will decide whether you are going to do surgery or not.
Whether the deep vein flow is normal or not.
How do you know that the deep vein flow is normal or not in Doppler? What are the criteria?
Sir, there will be phasic changes will be there, sir.
Yeah.
And sir, there will be augmentation present. Yeah. These are, sir, indirect.
One more point.
And sir, compressible.
Yeah, the deep vein should be compressible. There should be augmentation. There will be phasic variation during aspiration. Okay, these 3 should be present to say that patient doesn't have any deep vein thrombosis. Okay. Anything else? What is the next point you ask for? What will you do for the GSV SF reflex?
Sir, for testing reflex, sir. Sir, for SFJ reflex, the criteria is the duration of the reflex, the reversal of the flow should be for more than, sir, 500 milliseconds.
Yeah.
Usually, sir, 500 to 1 second. Sir.
Okay, more than 500. Okay.
Yes, sir. And sir, for perforators, we call the criteria as, sir, between 300 milliseconds or 500 milliseconds with diameter of perforator, well, the gap in the deep fascia more than 3 millimeters.
3.5. Okay, that's fine. So next thing is you have to go for a saphenophumeral junction. Look for an EPOF. There's a normal physiological reflex is there which lasts less than 300 milliseconds or so. But if it's more than 500, we have to take it as significant. Okay. Then,
what are the different perforators and where are they located? Enumerate different perforators, and
so there are more than 100 to 150 perforators. But there are few named perforators.
Few names.
Yes.
Sir.
There is, sir, Hunter's perforator, sir, which is in the adductor canal, sir. There is
how many centimeters?
Sir, usually, sir, sir, 15 centimeters from SFJ.
From which?
In the
from
mid
where?
thigh, sir.
From where?
From
SFJ,
where?
sir. SFJ, sir.
After
sir, there is Dot's perforator, sir. It is in the distal thigh, sir. There is Boyd's perforator, which is below knee.
Any time limit is there for the case presentation? I just want to know.
Ideally 1 hour, because you have to finish by 10 o'clock. One more case is there. So if you go to 10:30, we can make 15. We can take 15 minutes more, and we can end up.
So there is Boyd's perforator, which is below knee perforator. So there is Pocket's perforator. There is May Cusnal perforator, which is ankle perforator.
Shubham, there is a question. That's perforate and communicating veins. Are they same or different?
Sir, actually, I went through these, and there are many times it is interchangeable. Then it is a conflict.
No, Shubham. Both are different.
Both are different.
Communicating veins are the medial side veins at the lower half of the leg, allowing blood to flow from superficial to deep to the superficial vein. Both are different terminologies.
Perforator, by definition, it has to perforate the deep fascia. Usually it communicates between the superficial and deep veins. But if there's any communication between two veins, the same plane, same anatomy plane, for example, maybe the short long surface system, maybe the connection, or Giacometti vein is another communicating vein. They are not perforators, they are communicating veins only. So both are different. Okay, you have done, yeah.
I just like to say that certain veins open into sinuses and then into the deep veins, and certain open directly into the deep veins, right? So, and this is the difference between communicating veins and perforators.
So
one question I would like to ask: what is Bisgard's regime?
Sir, Bisgard regime is used for management of venous ulcers. Sir, it starts with education of the patient about the disease itself and the care which he has to take. Second is limb elevation, sir. Third is elastic stockings. Sir, fourth is I will go for 4-layer compression, 4-layer bandage, sir.
That is the main thing. 4-layer compression. That is the exact Bisgard regimen.
Yes, sir. Sir, 4-layer compression bandage. Sir, fifth is addressing use of antibiotics if required. Sir, sixth is surgical correction of the varicose veins.
What surgery will you do for this patient?
Sir,
what are the factors which decide what type of surgery will you do?
Sir, I would like to do EVLT, sir, in this patient because in our surgery.
Pardon?
Sir, EVLT, endovenous laser ablation.
Suppose there is no laser available, then?
Sir, if we don't have, if it is not available, then I will go for Tredelenburg operation, which is the.
What is that?
Sir, it is the flush ligation of the SFJ, sir. It does not include.
No. Tredelenburg has 3 components. Flush ligation forms only 1 component. What are the two components? What are the components of a Tredelenburg operation?
There's some, you strip, you ligate, there's something.
Sir,
I've given you a hint. There's something which goes on. We put an incision somewhere. We put something, some kind of a wire. Something we've tried to do.
Sir, stripping of vein. Stripping of the vein is not a.
That is, Tredelenburg operation has 3 components. One is flush ligation. Second is excision of a short segment of vein. Third is ligate. All the perforators there. All the branches to that saphenous vein junction. These 3 forms Tredelenburg operation. Then
what all will you ligate? What all will you ligate? There's a circle. What all will you ligate?
Sir, first of all, I would ligate the 6 tributaries, which is.
What are those?
3.
Sir, if 3, then sir, superficial epigastric, sir, superficial external pudendal, sir, then superficial circumflex ilex, sir.
What about other veins?
Sir, there is anterior accessory saphenous vein, sir. There is medial saphenous vein, sir. Apart from this, sir, there is superficial external.
What all veins you see there, you have to ligate it.
Yes.
Shubham.
Yes, sir.
I want to ask one question. At the flush ligation, if there is an arterial bleeding, which vessel get commonly injured?
Sir, common femoral artery.
Sorry?
So which artery is commonly injured at the SFA?
Sir, common femoral artery, sir.
Not common femoral artery. Given in Sabiston, commonly a sensitive question for undergraduate. Deep external pudendal artery.
Okay. Is there any role
under the long saphenous vein?
Is there any role of sclerotherapy?
Yes, sir. For sir veins, sir, the 3 millimeters, we can go for sclerotherapy, sir, or you can go for perforators. We can.
What is your agent?
Sir, we can use various agents, sir. Most commonly, sir, in our institute, we use tetradecyl sulfate, sir. But,
sodium tetradecyl sulfate.
Sodium tetradecyl sulfate, 3%, sir. Or we can use for 3% pyrocanol, sir. Or we can
Polydocanol. It's not pyro. But how will you make it? What's the advantage of using a foam, and how will you make the foam?
Sir, there is this method known as Tessari technique, where we take one part of the sclerotherapy agent, sclerosant, sir, and sir, three or four part of air, sir. Between the tri-way, we aspirate and inject, sir, to create foam, sir, and this foam is injected in the veins.
What's the advantage of foam?
Sorry, sir.
What's the advantage of foam rather than liquid?
Sir, the quantity of the sclerosant which is required is reduces. First thing, sir, and second thing, because sir, it also reduces the chances of getting the sclerosant into the deep system.
What are the complications of foam?
Sir, sir, if there is extra vessellation of the foam, sir, there is ulceration and sir, skin, and sir, there is superficial thrombophlebitis, sir. And sir, there is if it seeps into the deep system, there is DVT, sir. Patient can have allergy to it, sir. There can be vasovagal syncopal attacks.
Shubham, why do you have to use a foam? Why do you have to make a foam to inject? Why can't you inject it directly?
Sir, the quantity of sclerosant which is required decreases, sir. Second thing, if we use more quantity, sir, then the chances of the liquid getting into the deep system is more, sir.
Any other reason? More important? Foaming makes it stick to the intima.
Yes.
Dr. Shubham, can I ask one question? Dr. Srikumar asked you, what procedure are you going to do to this patient? You just replied EVLT. Are all patients amenable to EVLT because you have an EVLT machine with you? Don't you look at the Doppler prior to deciding on whether you can treat with EVLT or its ideal treatment?
Sir, we go for Doppler. So we rule out DVT first, and sir, in this case, I set for DVT because the patient has venous ulcers. Sir.
How do you know there is no DVT or a proximal obstruction from the Doppler?
Sir, like I said, sir, there is, sir, compressibility is the most important feature, sir. If there is DVT, the veins are not compressible.
Yeah, I asked about proximal obstruction. Suppose a patient has got an iliac vein obstruction. How would you?
Sir, the phasic flow is sir, hampered.
Yeah, good. The loss of respiratory phasicity will not be there.
Compression, there is augmentation flow loss.
Yeah. Second thing I wanted to ask is, how will you select a patient based on a Doppler to the treatment modality? Is Doppler important in identifying or selecting the patient to a particular modality, or in other ways, are all patients amenable to laser treatment or RFA treatment? Or what are the contraindications to endovenous laser therapy or endovenous ablation? Any contraindications?
Sir, sir, if there is DVT, this is first thing, sir, and if the diameter of the veins
if there is more, DVT, do you operate on the patient?
No, sir.
So
that is contraindicated for the surgery, sir.
Yeah,
and
fine.
Second thing is, sir, if there is, sir, the diameter of the vessel is high, sir.
Yeah, more than 2 centimeters generally we don't take the great saphenous vein in the standing position. Second,
sir,
any characteristic of the great saphenous vein? If the vein is too close to the skin.
Yes, sir. Yes, sir. If it is within 3 millimeters of this, 5 millimeters of the skin, sir, then we do not do, because the chances of thermal injury to the skin is more.
How do you decrease thermal injury during endovenous ablations?
Sir, thermal injury can be reduced, sir, by administration of tumescent anesthesia that does the hydrodissection, sir, and pushes the vein apart along with the compression of the walls of the vein. It pushes the vein more deep, sir. And sir, also we can use sir, intraoperative. We can use the sonography to ensure the probe is at adequate depth, sir, and inside the lumen, sir.
Mention 3 complications of an endovenous laser ablation or RFA treatment.
Sir, the injury to skin, sir, injury to vessels, and
Which vessel is commonly injured? What injury do you mean?
Sir, if we should place the tip, sir, sir.
What injury can occur?
Sir,
To the vessel.
thrombosis can occur, sir.
Heat-induced thrombosis of the deep vein and perforation of the vessels by laser fiber.
Yes.
Then third complication?
Sir, injury to the nerves.
Failure of treatment can occur, no?
Failure of treatment, yes, sir.
Pain is there.
15%.
So what is the gold standard in treatment of, one more question, just last question from my side. What is the gold standard treatment for primary superficial venous insufficiency now?
Sir, primary, sir, I could not get the question, sir.
Your varicose veins, what is the gold standard treatment now?
Sir,
as per your Bailey and Love.
Sir, radiofrequency ablation, sir.
Endovenous
therapy.
ablations.
Yes, sir. Yes.
Yes, sir. Dr. Srikumar.
Shubham, it's good. Excellent presentation. Only last 5 minutes. This patient, when you do a Doppler, there is deep vein thrombosis with a non-healing ulcer, with the varicosities.
Yes.
How will you manage? What are options?
Sir, I have to do the surgery because the venous ulcer will not respond. I will follow the Vizard regimen till the time the patient is taken to the surgery. I will go for 4-layer bandage. I will go for limb elevation, education of the patient for the foot care, and sir, continuous wearing of the stockings, sir. And sir, then I will plan the patient as that.
Still not responding to it. He has tried discards. Patient has severe post-thrombotic syndrome, patient is recurrent ulcerations, then what will you do?
Sir, I will increase the pressure at the ankles.
Okay, you can increase the how long? What's your limiting factor of applying pressure?
Sir, it is the ABPI, sir. If,
yes. Patient should have a normal ABPI or more than at least 0.7 to do pressure. Okay.
Read it out, sir,
yeah, good, excellent. So then what will you do?
Even if that fails, sir?
Yeah.
Sir, apart from that, we can also go for, sir, negative pressure wound therapy. Sir.
Will you do an MRI?
Sorry, sir?
Will you do an MRI? Or what are the indications of an MRI, MR venogram in a venous ulcer?
Sir,
will you do an MRI, MR venogram in this patient or in a patient with a non-healing ulcer?
Sorry, sir, I didn't answer.
Okay, what is the method? Yes, you have to do MR venogram if patient is not responding to this treatment, or if the patient has evidence of post-thrombotic syndrome. Then your option is go for a MR venogram to see the status of iliac veins. Last question: what is Methana syndrome?
What is Methana syndrome?
Yeah.
Sir, it is It is a congenital anomaly of the venous system.
Which vessel compresses which vessel?
The right iliac artery compresses the left iliac vein.
Which right iliac artery?
Sir, right internal iliac.
Right?
Sorry, right internal iliac, sir, compresses.
Internal. How can right internal iliac compress the left internal right iliac vein?
Sorry. The right external iliac artery compresses the left external iliac vein, sir, because of which there is, sir, unilateral.
No, sure. It is a right common iliac artery compresses the left common iliac vein. That is Methana syndrome. Okay. Anyway, you performed excellent. Can I have any more questions, or shall we wind up?
I think he had managed all the tough questions. Now I want the words from Kanna sir. He has been keeping quiet from all the time. Sir, Kanna sir, I think you should chip in now.
I was not speaking anything because Shubham was doing so excellent.
You are the internal examiner.
Anyway, sir, it's excellent. He's performed very well. He gave answer to most of the questions. Even though he was bombarded with many questions, he managed everything. Excellent.
I think I will just like to sum up whenever we think of the varicose veins, the treatment of that, it is not just one modality which is there. It is always a multimodality treatment. From starting the lifestyle changes to the few drugs like the flavonoids, to the compression treatment, and then going for the surgical treatment, which may be the open surgical treatment, or you go for the endovenous treatment. Now, in the open surgical treatment, you have to do a flush ligation at the saphenofemoral junction. You have to ligate at least the 3 tributaries which are there. Sometimes there are 4 or there are in the 5 maybe there. And then you have to take care of the stripping of the GSV also. Now, as far as the endovenous treatment is concerned, you basically divide into 2 types, whether they are the thermal treatment or the non-thermal treatment. In the thermal treatment, you can use a laser, you can use a radio frequency ablation, you can use a microwave, or you can use the steam treatment for that. While in the non-thermal variety, which is there, you can use the various types of the sclerotherapy, which is there, polydocanol or the sodium tetrahydroxide sulfate, all these can be used. And then there's a combination is there, what is called a MOCA. MOCA is a mechanico-chemical ablation where you combine the endothelial damage along with the sclerotherapy. And then nowadays is the cyanoacrylate glue which is there, which is used for occlusion of the vein. And then the most recent one which is there is the what is called a HIFU, high frequency ultrasound. And you can use this high frequency ultrasound to block the saphenofemoral junction. Now, whenever you are doing all these things in the endovenous treatment, you must be very sure that you do not produce what is called a E-HIT, which is a endovenous heat-induced thrombosis, which is there. And that is why you always keep your tip of the laser or the RFA at least 2 centimeters proximal to that. But now the people have shown what is called a crossectomy. Crossectomy, which is done right at the level of the saphenofemoral junction where we are ligating. That has been also proved to be in expert hands safe. But otherwise, it is always better that you keep your tip of the catheter, whether laser or the RFA, 2 centimeters proximal to that. And in the case of glue, it should be 5 centimeters proximal to that. Because if the glue goes into the deep veins, there will be a lot of the problem may be there, and it may really lead to the bad DVT. So sometimes if there's a different category of the E-HIT which are there, and sometimes you require to give these patients the anticoagulant treatment to prevent the DVT. So this is overall the treatment of the varicose veins. Now in this patient, because we have the facility for the laser treatment here, so our treatment in these patients is that we give in these patients the laser to the proximal part. We do not give the laser beyond the knee. It is only above the knee which is done. And for the beyond the knee, if there are any perforators or if there are any veins which are there, we do the sclerotherapy of that. So through the same, we go through the veins either with the help of the small needles we puncture the veins and carry out that, or we use the Venflon to put it into the veins if it is there, and we do the sclerotherapy. Sometimes if there are big veins which are there, we'll do the mini phlebectomies. So in fact, in all these cases, you require a combination of the treatment to treat a case of the varicose. Thank you.
Sir, thank you very much for summing up the entire recent advances in one go and the most updated management issues. Faculty, any other faculty want to add up any points? Shubham, do you have any questions to ask the faculty? Any doubts to be clarified? Anything you want to ask, Shubham?
The communicating veins versus perforator veins.
Come with your question again.
Rajiv sir was telling about the communicating vein and perforators. So the direct and indirect perforators he was telling about. Then he said that communicating veins are different. I could not hear that part.
Communicating veins are like someone also said, if they are in one plane, they can have communicating veins between the short saphenous vein and the long saphenous vein, right?
On the medial side of the lower half of the leg.
Right. But perforating veins, they perforate either direct perforators or indirect. Indirect, they go into the sinuses and then open into the deep veins. Direct open directly into the veins.
Communicating veins are usually the named veins which are there. Like Giacometti vein which is there, it's like a named communicating vein which is there, which is from the short saphenous to the long saphenous system.
Then you can have the anterior accessory veins, you can have the posterior accessory veins. And all those perforators which are there in the leg, in the case of the GSV, these perforators are not over the great saphenous vein. They are over the posterior axial vein which is there. So all those named veins which are there, they are the communicating veins here. While the perforators which are there, those are small, which are piercing the deep fascia, and there are so many perforators which are there. So those are the perforators which can be a direct perforator, or they can be indirect perforators.
Thank you very much, sir. With the permission of the faculty, we move to the next case. Good luck to you, Dr. Shubham. You did well. Keep up, and we request you to stay back for the second case also. Preeti, can you try sharing your PowerPoint now? Please switch on your video and start your presentation, Preeti. Please tell about you, your unit chief, and your HOD, and then start your presentation. Preeti, are you with us? Preeti, maybe you have to use some other device to come. We are unable to hear you. Preeti, I would request someone else to show the PowerPoint. You please log out of this device, use your mobile phone or something. The same problem is still existing and we have not sorted out.
I'll share the screen. I'll share the screen.
Yes, sir. Thank you very much, sir. Very sorry, sir.
No problem. She need to exit out. I'll share the screen.
You can use your mobile phone and start your talking. You check your mic settings in your left lower thing. You use one of your friends' mobile or something to come into the line, Preeti Vardhan. It is. Ishan sir, is it your screen, sir, now what we are sharing?
No. I cannot
please
share.
Unshare, Preeti Vardhan. Please unshare your screen.
Yeah, now I can share. I can share.
Yes, sir. Please share your screen.
Yeah, 1 second, sir.
Preeti, I would request you to log out, log in with somebody else's device.
Yes, sir.
Yes. Please log out from your earlier device.
Yes, sir.
We are able to hear you well with this device.
Yes, sir.
Sir, I think I would request you to share, sir. Are you okay, sir? Ishan, sir?
Yes, I'm trying.
Yes, sir. Yes, sir. We will wait, sir. Sorry for making you to do this as a faculty.
No problem. No, it's not happening from my end right now at this moment of time.
Sir, please unshare yourself, sir.
I'll do that.
Hello.
Yes, ma.
Hello.
Preeti, you have your other system on, ma? Ethan, sir?
Yes, sir.
I'm not, it's not getting shared right now. I don't know why, what is happening. It never happened.
I think Srinivasan sir is trying to share.
Yeah,
Let us
that
see.
is, yeah.
Thank you, Srinivasan sir. Thank you very much. Preeti, you start your presentation, Preeti. Preeti Vartan.
Sir, good evening, sir.
Please start your presentation, ma. Yes.
Good evening, sir and ma'am. I'm Preeti Vardhan, second year postgraduate from Peripheral Medical College. I'm going to present about peripheral vascular disease under the guidance of Dr. Alex Edward sir, Dr. Janita ma'am, Dr. Sugitra sir, and Dr. Rajmohan sir.
Are you able to see my slide?
Yes, sir.
Yeah, present.
Yes, sir.
Sir, next slide, sir, please. Sorry.
And went to the next slide only.
Sir, we are not seeing the full screen, sir. We are, sir, I would request first to unshare this, sir. Yes, sir. Please come out of the screen share mode, like full screen mode in the PowerPoint, sir. You try advancing the slide, sir. Yes, sir. Like that, you keep going, sir, because.
Yes, sir.
Preeti, please go ahead, Preeti. Sorry,
Yes,
sir,
sir,
for making you to
no
do this.
problem, sir. Preeti, yes.
Yes, sir.
Start
Yes, sir.
present.
Sir, I'm Mr. X, a 40 years male, painter by occupation from Tirunelveli, with chief complaints of pain over left lower limb for 3 months and pain over right lower limb for 1 month. History of presenting illness. Patient was apparently normal 3 months. Patient was apparently normal 3 months back, after which he developed pain in left calf, intermittent claudication, crampy type of pain after walking for a distance of 200 meters, and which was relieved on taking rest. Now the distance reduced to 100 meters. Pain over right foot for 1 month after walking for a certain distance is 100 meters, radiating to cough, relieved on taking rest. Patient had history of pain at rest during night, which awakens him from sleep, and he manages by holding his hands with food. History of blackish discoloration over left great toe for 15 days. History of numbness over left foot on and off. No history of trauma. No history of ulcers or skin discharge. No history of fever, chest pain, or breathlessness. No history of loss of consciousness or blackouts. No history of abdominal pain. No history of impotence. He is not a known case of diabetes or systemic hypertension or cardiac disease. Past history. No history of similar illness in the past. No history of any surgeries in the past. And he is not a known case of diabetes or hypertension or hypercholesterolemia or cardiac disease or epilepsy or pulmonary tuberculosis or COVID. Personal history. He is a smoker for 15 years. Smokes 10 cigarettes per day. And he is an alcoholic for 15 years and drinks 180 ml per day. He takes fixed diet and he has disturbed sleep and normal bowel and bladder habits. Family history. No history of similar illness among family members. Treatment history. No history of any treatment for a current illness or a chronic illness. He used to take analgesics on and off for claudication pain. Summary. A 40-year-old male painter by occupation, chronic smoker and alcoholic, with no comorbidities, with complaints of intermittent claudication and rest pain in left lower limb for 3 months, with blackish discoloration or left great toe 15 days, and intermittent claudication or right foot 1 month.
Preeti, I want to disrupt you.
Yes, sir.
How it is possible that there is a what you told that there is a pain in the left leg from last 3 months?
Sir?
Pain in the
Yes,
left,
sir.
what you told? That
Yes,
is
sir.
pain in
Pain
the
in
left leg is from the last 3 months.
3 months. Yes, sir.
Then Blackie discretion from 15 days on the same.
Yes, sir. Yes, sir.
leg.
Same limb. Yes, sir.
And on the opposite right side, there is a
Yes,
pain
sir.
from last 1 month.
1 month, sir.
Please justify whether it is acute or chronic, whether it is possible in a short duration, whether it is possible.
Yes, sir. It is mostly chronic, sir.
Then how it is possible within 3 months? How the progress will be there?
Yes, sir.
The history is
How
too
it is
short.
possible?
The history is too short for a chronic kind of thing. Just in 3 months, it progresses from pain to
It is possible.
Sir, a patient actually.
There is no progressive decrease in the claudication distance. You are not mentioned.
Sir, I mentioned, sir, it decreased to 100 meters, sir. From first, initially it was 200 meters, sir. Now it is only 100 meters, sir. And
but duration is very small, no? The duration
yes,
is
sir.
very short. It is
Yes,
not
sir.
possible.
The patient noticed and he took it significant only for 3 months. Before that, he is painter, so he had regular leg pain, sir. So he told the significant history only for 3 months, sir.
Okay, how will you elicit progression of the claudication? How will you elicit the progression of claudication history? What are the different points they have mentioned that are mentioned in books? How to elicit history of claudication?
So claudication.
Progression of claudication.
Sir, first, initially he had in food, sir. Then he had in a cough, sir. And claudication distance is decreased, sir. And he had recently he got a rest pain at night alone, sir. Rest pain, sir. So it is progressive, sir.
One more point: Blackie discoloration.
Sir?
Blackie discoloration, gangrene.
Yes, sir. That is for 15 days, sir. Yes, sir.
Okay.
That is for 15 days only, sir.
Then whether it is acute ischemia or chronic ischemia? No? By your history?
Sir, it is chronic, sir.
Chronic ischemia. What are the points in favor of chronic ischemia?
Sir, there will be shorter duration, sir, in acute more than this.
What are causes for acute ischemia?
Sir?
What are the causes for acute ischemia?
Embolus, sir. Embolus from distance.
Your history is not proper. Okay, proceed.
Yes, sir.
Proceed.
Sir, examination. General examination. A patient is examined after obtaining consent in sitting position with legs hanging by the side of the bed. Patient is conscious, oriented, afebrile, moderately built and nourished, and hydration status is fair. No pallor or cyanosis or clubbing, no generalized lymphadenopathy, nicotine staining of gums and fingers are present, and no signs of any atherosclerosis. Blood pressure is 120/80.
No signs register of atherosclerosis where?
Sir, arcus analysis then xanthelasma. Sir?
What is definition of claudication?
Sir, I couldn't get you.
What is claudication? Define claudication.
Claudication is intermittent pain after pain occurs after a certain exercise, and it is
classically defined. how it is classically described? These are commonly asked questions, commonly asked definition.
Yes, sir.
What is claudication?
It is
claudication?
sir, claudication is
what is pre-gangrene? What is claudication?
Sir, claudication is reproducible pain.
It is a cramp-like pain felt in a specific muscle group due to deprivation of blood supply. This is the claudication. And claudication distance at which patient experiences pain after taking the rest, he can able to walk.
Yes, sir.
Same distance. Please rectify. Okay,
yes,
proceed.
Sir.
Proceed.
Blood pressure is 120/80 mmHg in left arm in sitting position, and pulse rate is 88 per minute in left radial artery, normal in volume, character, and amplitude. Saturation is 99% in room air. Height is 174 centimeters, weight is 78 kg, and BMI is 25.7. Local examination and inspection, there is a blackish discoloration over the left great toe, and brittle nails are present in both limbs. There is diminished hair over left leg, loss of shininess over left lower limb.
What does it suggest? What does it suggest?
It's sir.
What does it suggest? Blacky discoloration of the great toe, brittle nails, diminished hair.
Yes, sir.
What is the terminology for that?
Sir, there is a vascular compromise, sir.
Not vascular compromise. Signs of chronic lower limb ischemia. Signs of
Yes,
chronic
sir.
ischemia.
Chronic is yes, sir. It is signs of chronic ischemia.
Proceed.
Yes, sir. No ulcers are discharged, and no varicosities.
Preeti, is there any smell? Have you mentioned? Have you seen if there was any smell there?
Which one, sir?
Was that black
Yes,
and toe smelly?
No,
is
sir.
Is it important to know whether it's smelly or not?
Yes, sir.
Why?
Whether
you've not mentioned it, that's why I'm asking you. Why is the smell important?
Sir, if it is infected and it is a wet gangrene, there will be foul smell, sir.
So you must mention. This is very important.
Yes, sir. Actually, it was not gangrene, sir. Just a slight discoloration.
So you just say that there was no smell.
Yes, sir. Okay, sir.
Then what is pre-gangrene condition?
Sir, pre-gangrene condition is the blood supply to the tissues is precarious, so that after that the tissues may not be alive, sir. It is going to become gangrene, sir.
What are different signs of gangrene? What are the different signs? Classical 5 signs of gangrene. Classical.
For
5 signs
sir,
of classical 5 signs of gangrene.
Sir, dry, shriveled.
No, I'm not asking the types. I'm asking the signs. I'm not asking the types. I'm asking the signs.
Sir, pulselessness, sir. Absent pulse.
Loss of pulsation is the word. Loss of pulsation.
Yes,
Number
sir.
1.
Paresthesia, sir.
What is paresthesia?
Sir, loss of pains there at the site, and site proximal to gangrene will be hyperesthetic, sir.
No. There are 5 classical signs.
Pain, pallor, pulse. Yes, sir.
No, I'm not talking about signs of inflammation. I'm asking signs of gangrene. 5 classical signs. This is the
yes, sir. That is cold. Sir, cold limb, sir.
Cold, clammy feet. What yes, will you call it?
Sir.
Loss of temperature.
Yes, sir. Loss of temperature. Yes, sir.
See, explain in a very simple language. This is not an exam going on. Be very much relaxed. You can have a glass of water. Plenty of time is there. There is no one is going to pass or fail you here. All the senior oracle stalwarts are present here just to guide you.
Yes, sir.
So be very much relaxed and comfortable. There are 5 classical signs of gangrene studied in our undergraduate level, and at the basic book, that is S. Das.
Yes,
Have you read S. Das? Did you read S. Das?
Sir. Yes, sir.
So what are the 5 signs of 5 basic signs? You said 1, that is loss of pulsation, loss of temperature. Other than
Color change in
Which
color.
color? First it starts pale.
Paler, sir.
And before it becomes black, there is something.
Paler, sir. Cyanos.
Which is that color? Bluish purple, you call it.
Purple. Yes, sir. Cyanosis, sir.
Again, you are going to a very technical term. No, you should
okay,
not.
Sir. Okay, sir. Bluish.
Speak in a very simple language to the examiner.
Yes, sir.
So you don't get involved in a very precarious or a tricky situation where the examiner bamboozles you.
Okay.
Be in a very simple language. Yes. So one more very important point. Two very important points left. Loss of pulsation, loss of function. There
Yes,
are 5 classical signs. It will be asked by each and every examiner, whether it's the internal or the external. You should know.
Yes, sir.
Okay, fine. Go ahead. What are the causes of gangrene?
Sir, it can be due to trauma or infection or vascular events, sir.
What are the cardiovascular causes for gangrene?
Sir, atrial fibrillation causes left atrial clot and it can embolize and cause a thrombus in periphery, sir.
Is cervical rib a cause for gangrene?
Sir?
Is cervical rib a cardiovascular cause for a gangrene? Cervical rib.
Yes, sir.
Why?
Cardiac vegetation is also another cause, okay?
Yes, sir. Yes, sir. Cardiac vegetation.
Preeti, why do you think your patient was sitting with his, holding his feet, with his, cupping his feet in his hand?
So because his limb is cold and warmth in his hand, he can feel it, sir. So that's.
So they use the warmth of the hands.
Yes,
why?
Sir.
What happens to that then?
So that causes vasodilatation and it can relieve pain, sir.
Good.
What is cry of the dying nerves?
Sir, it is a rest pain, sir. Rest pain is described as crying of dying nerves.
What is pathophysiology of rest pain? Why there is rest pain? Ischemia of which part?
Sorry.
Rest pain?
Yes, sir.
Ischemia of which nerve?
Which, sir, most distal nerve, sir.
Ischemia of the somatic nerves.
Yes, sir. Somatic nerves, yes, sir.
Ischemia of the somatic nerves.
Somatic nerves, yes, sir.
Pain is more in the night.
Sir, during night, effect of gravity is eliminated, sir. So he is relieved of pain when he put the hand, the legs by side, and on elevating it, vascularity is decreased in the distal limb, so he has more pain in night.
Which substance is produced and swiped away?
So substance P, sir.
What is that P substance?
Sir, it is a neurotransmitter. It is a product of anaerobic metabolite. It is an anaerobic metabolite, sir. So in vascular compromise, in ischemia, there is more anaerobic metabolism, which creates substance P, and it stimulates the pain receptors and causes pain, sir.
What is Raynaud's phenomena?
Raynaud's phenomena is it is events of pulselessness and pulseless and pallor, sir. It has 3 phases, sir. Raynaud's phenomena.
One single line definition: intermittent attacks of something and something. That is Raynaud's phenomena, and that's something known as Raynaud's disease. They are 2 very different entities.
Yes, sir.
Though bearing the same name.
Yes, sir.
Again, relax yourself. Calm down. Relax yourself.
Yes, sir. Yes, sir.
Okay, what is Raynaud's disease?
Sir?
What is Raynaud's disease and when is Raynaud's syndrome?
Sir, Raynaud's disease is it is due to exposure to cold. There is a vasospasm in peripheral.
That is Raynaud's phenomenon.
Phenomenon, yes, sir. Phenomenon, sir. Raynaud's disease is secondary to vascular disorder, sir. There is in Raynaud's disease only there is intermittent events.
No. Not expected at your level. Come on. Definitely not expected at your level.
Okay, go ahead.
No problem.
So, what is your impression now with your examination findings? We'll come back to it. Cool down. Yes.
Yes, sir.
Have a glass of water and cool down. Continue.
Okay.
Okay. What is your impression about this patient?
Sir, it is he's a young age male who is a chronic smoker, and he has no comorbidities.
Yeah. Okay.
And he has no any signs of atherosclerosis.
Okay. What are the signs of atherosclerosis we anticipate in this patient?
Sir, obesity may be present, sir.
Pardon?
Sir, obesity.
Obesity is a sign of
not a
sign.
No, sir.
Those are a very common cause. Just most common.
Yes, clinical presentation of atherosclerosis.
Yes, sir. Sir, arcus senilis.
Common thing.
Sir, pulse calcify.
No. What are the common presentations of atherosclerosis?
Sir, cardiac disease.
Yes. What is a cardiac disease there?
MI, sir. Myocardial infection.
Angina pectoris. Okay. Then.
Yes, sir.
Then.
He has no any cardiac diseases, sir.
No. My question is, what are the presentations of atherosclerosis? One is cardiac disease or myocardial infarction, IHD, whatever it is. Okay. What are the effects in other organs? In such a patient, what are the systems history you have to ask for? Because you are anticipating a systemic vascular disease, which is not a common, it's a local disease, systemic disease.
Yes, sir.
It can happen in all organs. So,
yes, sir.
What are the other organs which can be affected by atherosclerosis? And what is the presentation? One is heart. Okay.
Sir, abdomen pain. Abdomen pain.
Like sir is saying, what will happen to the brain?
Sir, cerebrovascular accidents, sir.
Okay.
What will happen to the kidneys?
Yes, sir. Cerebrovascular.
What will happen?
Abdomen.
Renal artery stenosis.
Yes, sir.
Abdomen, kidney.
What's the common presentation of renal stenosis? How will the patient present?
Anemia.
No. Now, yes, they present as chest pain, the severe they present as stroke. If there's renal artery stenosis, what is the presentation? What's the common symptom or common sign? It's hypertension.
Yes, sir.
They'll have renovascular hypertension.
Hypertension, yes, sir.
Even peptic ulcers can have. Even peptic ulcers. Yes.
Yes, sir.
And what is the classical what will you find? Classical palpation and on auscultation. What is the classical sign you will hear in the heart?
Murmur, systolic murmur.
Yes, a cardiac systolic murmur you hear.
Yes,
okay, sir. I think you just enumerate what will be your what will you do in an inspection? Just enumerate. Don't explain in detail.
Sir, inspection, sir.
Yes.
Sir, there is a blackish discoloration of the left great toe.
No, don't go about the patient. I'm just asking you in general. We know what we are seeing in the presentation. What all you will find. First, what all you'll inspect. First thing, what you'll see. Just enumerate the points. We don't want to go into detail right now.
Okay, sir. Sir, there is any skin changes?
Number one. Number two?
Hair loss, sir. The loss of shininess of the limbs, sir.
Won't you go for the ischemic signs after the color change?
Yes, sir.
Yeah, so tell that.
Brittle nails, sir. Brittle nails, and then muscle wasting, then ulcers or discharges, sir.
See, stick to that, please.
Okay.
Burgess postural test. What is that?
Sir, Burgess postural test, yes, sir.
Yeah, what is that?
Sir, raising the limb for a certain degree, there will be pain and pallor, sir. Normally.
What is that degree? What is that angle?
Sir, Burgess angle, Burgess vascular angle, sir.
90 degree, 180 degree, 270 degree, 360 degree. How much?
Yes, sir. Sir, normally it is 90 degrees, sir. If it is less than that, in ischemia, it can be very low, sir.
And what is that cynetic hue called?
What
is the cynetic hue?
Sir, I couldn't get you.
Cynetic hue. Cyanotic hue. There's something you will get in a Burgess postural test. What is that? When you will find in an inspection a cyanotic hue? After how many minutes?
For 5 minutes.
Within 2 to 3 minutes.
Yes, sir.
What is capillary filling test or a capillary filling time?
Sir, after Burgess postural test, patient is asked to put his leg by the side. After that, the pallor will disappear and the toes will get.
How will a normal leg look like? Which color
yes, sir,
normal leg will look like?
Toes will become pink. Toes will become pink, sir. The time taken for that is called capillary filling time, sir.
How many seconds? Roughly.
Sir, it should be 5 seconds, sir. If it is greater than 20-30 seconds, it is severe ischemia, sir.
Nothing can happen in 5 seconds. It will generally take 20 to 30 seconds.
Okay.
What is venous refilling?
I think better we allow the candidate to present the case and go ahead with the discussion instead of asking directly to them. This is allowing the patient candidate to complete the pictures and what he has done, what is his spending, and then based on that the discussion will be there.
Priti, you start from the palpation of the peripheral vessels.
Yes, sir.
You finish this one, isn't it?
Yes, sir. Palpation, the left lower limb. So shall I proceed, sir?
Yeah, please.
Yes, sir. The left lower limb temperature is relatively decreased, sir. Tenderness is present over left calf and right foot, sir. There are other sensations over both limbs are normal. There is no restriction of joint movements, and the capillary refilling time is delayed, sir. It was 6 seconds in this patient. There is no edema, no regional lymphadenopathy, lymph nodes. And, examination of peripheral pulses. Only in lower limb, only femoral pulse was palpable, and the other distal pulses were absent, sir, in both lower limbs. Then upper limbs, radial, ulnar, brachial, axillary, and subclavian, common contractile, and superficial temporal. All pulses were present, sir. There was no vessel wall thickening, no palpable thrill, and no bruit here. And the gait of the patient was normal.
What are methods for palpation of the popliteal artery pulsation?
Sir, there are 3 methods. There are 2 methods of palpation, sir. In a supine position with a knee flexed to 40 degree, with 4 fingers in the flexor aspect in the popliteal fossa. The fingers are flipped between between popliteal fossa, and it is palpated against proximal tibial condyles, sir. And pulse can be felt, sir. In prone position with knee lightly flexed, it is palpated against the distal femoral condyle, sir.
Femoral convex. Okay. Any other?
Cross-leg test.
Yes, sir. Cross-leg test with one limb over the other, crossed over the other in patient sitting position, with the patient attention diverted from his leg. There will be oscillatory movements of the toes, which is synchronous with the popliteal artery pulsations. That is called Fusick test.
Just okay.
You complete your presentation.
Yes, sir. Examination of other systems. CVS is S1, S2 hurt, no murmur. RS is the bilateral artery present, no added sounds. Per abdomen soft, bowel sounds present. Spine and cranium, no obvious abnormalities was present. Diagnosis, it is a case of bilateral peripheral artery occlusive disease, probably due to thromboangiitis obliterans.
Preeti, you have to mention the gait. Is your patient being able to walk or not? Can he walk?
Yes, sir. Yes, sir. He is able to walk, sir.
Can he walk independently? Does he need any support? What
No,
is
sir. His gait is normal, sir.
Look, you have to mention all this, right?
Yes, I mentioned.
Yes. Does he have flexure deformity, fixed flexure deformity of his limb? If he's sitting with his limb flexed all the time, he's bound to develop flexion deformity. Have you seen whether the limb can be extended completely?
Yes, sir. He is able to complete.
All this has to come in your examination.
Sir, I mentioned, sir.
Okay, I might have missed it, but
you mentioned gait of the patient is normal.
But what about his? Okay, but I just missed it. You have to stress on it. Okay.
Yes, sir. Okay, sir. Thank you.
Yeah, sorry about it.
What is disappearing pulse? You didn't mention about the disappearing pulses or any because palpation of pulse of the vessels is the same, one of the most important palpatory examinations to be done.
Yes, sir. Sir, disappearing pulse is in an ischemic limb with a collateral formation. The occlusion is masked by pulse. Patient is asked to exert to do some exercise. After that, it is palpated. Then the collaterals are not sufficient to compensate. So now the present pulse will be absent now, sir. This is called disappearing pulse, sir.
What is a crepitus? Crepitus. What is a crepitus? Yeah. So whether it's an inspectory finding or a palpatory finding?
Sir, it is a palpatory finding, sir.
What is
it is, sir. It is seen in dry gangrene, sir.
Dry gangrene?
No, wet gangrene, sir. Sorry, sir. It is gangrene, gas gangrene. Gas gangrene.
Is a classical.
It is due to accumulation of gas beneath the skin, sir.
Skin or the muscles?
Subcutaneously, sir, in muscles, sir. Sorry, sir.
Preeti, by your examination, can you point out which artery is involved here?
Sir, it can be femoral, sir. Femoropopliteal occlusion.
Do you know what are angiosomes? Have you heard of it? Angiosomes?
Yes, sir.
What are they? Like dermatomes?
Yes, sir.
The angiosomes,
yes, sir.
Where arteries are.
Yes, sir.
Have an area which they supply.
Yes, sir.
So the great toe is supplied by which artery usually?
Dorsalis pedis. Sir, digital arteries.
Right, which is a branch of?
Sir, anterior tibial.
Peroneal artery.
It's a peroneal artery. Yes.
Peroneal artery. So most likely to be involved. Good. How would you proceed in this case now?
Sir, I will confirm the diagnosis, sir, by doing a Doppler scan.
well, the Dopplers can tell you the diagnosis. What do you think clinically? I mean, why do you want to get a Doppler straight away? What are the indications of getting a Doppler?
So
clinically, what do you think you are dealing with?
Sir, it's a case of peripheral artery disease, sir, occlusive disease, and due to thromboembolic Hamilton's mostly, sir, probably.
So you think it's TAO? Okay.
Yes, sir. Yes,
so
sir.
how will you distinguish between TAO and atherosclerotic disease?
Sir, first by age of the patient, that is he's less than 50 years of age, and
what is Shinoya criteria? What is the age?
Yes, sir. Shinoya less than 50 years of age, sir, and history of smoking is present, sir.
Okay. What is ideal age for TAO or Berger disease?
40, sir. Less than 40.
Less than 40.
Yes, sir.
Okay, well, Shinoya says 50 years, onset before age of 50 years. What else? What are the 5 criteria for Shinoya?
Sir, less than 40 years, history of smoking, then superficial phlebitis, then superficial phlebitis is present, sir. Just smoking. Then there is intrapopliteal pulses are absent, sir.
And most important
is absence of comorbidities, diabetes or hypertension.
Yeah, risk factors for atherosclerosis, other than smoking.
Yes, sir.
Okay. What else? What else do you think is the difference between?
Sir, a medium and a small vessel is involved in TAO, sir.
Okay, very good. What else?
Large and medium vessels are involved in atherosclerosis.
Okay. What else?
Then the in wall, sir, vessel wall, panarteritis is present in TAO, sir. Whereas atherosclerosis intima is involved, sir.
What else? What else?
In TAO, that arteries, veins, and nerves are involved, sir.
Okay.
Then
what else? Yeah, microthrombi.
Yes, sir. Microthrombi. Yes, sir. Sir.
There's diffuse segmental involvement.
Yes, sir. Segmental involvement is present in TAO, sir. Yes, sir.
So, okay. So now you think you'll get a Doppler done. What are the indications for a Doppler? Why do you want to get Doppler done?
Sir, there is absent pulses, sir. To whether to see the site of occlusion, if any present. And sir.
Okay. What else?
To determine the flow, sir. Whether it is, sir.
Okay. What all do you think you look for while doing a Doppler? Outside the vessel, within the wall, within the lumen.
Yes, sir. Within the lumen, there is a aneurysm can be seen, sir. Then flow, other type of flow can be seen, sir. Then thrombus, if it is present, it can be seen, sir.
What is a pressure index?
Ankle brachial pressure index can be seen using handheld Doppler, sir. It is.
What is that pressure? How much is that pressure? There's a range to it.
Sir, normal is 0.9 to 1.1, sir.
If it's 1.3?
Sir, if it is 1.3, it is abnormal, sir. But in
how it becomes abnormal? Why it becomes abnormal?
Sir, because due to increased in lower limb pressure, sir.
That's a good sign. If a good increased pressure means that's increased flow. It cannot be a vascular disease.
Sir, but in old age and atherosclerosis, the vessels are calcified, sir.
Yes.
So it can be a false negative, sir.
Yes.
So what will happen if the ankle pressure goes below 30 mm of Hg?
Sir, ankle, it is critical limb ischemia.
What are the criteria for critical limb ischemia?
Sir, recurring rest pain which requires regular analgesics, and ankle brachial pressure index is less than 50 in 50, and toe pressure index is less than 30. Then there is, if it is an ulcers and skin tissue necrosis, it is critical limb ischemia.
What is Brown's vasomotor index?
Sir, Brown's vasomotor index is trial block. Sir, it is criteria for trial block, sir. It is done by measuring the temperature, rise in temperature after giving a local anesthesia. There is temperature rise, sir. Difference in temperature rise in lower limb and different temperature rise in oral cavity is measured and divided by temperature rise in oral cavity, sir. If there is a response to trial block, then lumbar sympathectomy can be done. It is called Brown's vasomotor index.
It is an investigation for the vasospasm too.
Yes, sir.
Vasospasm.
Yes, sir.
Okay, in this patient, you have done an ABI. But can you define ABI?
Sir, ankle brachial pressure index is highest pressure in ankle, highest pressure in lower limb divided by highest pressure in the upper limb. Sir.
Okay, that patient, yeah, the ABI is 1.3. Then can you do anything, because it is due to calcification of the vessels? Then what will you do? Then what will you do?
Then a duplex scan can be done, sir.
Straight away? What extra to be? ABI is purpose of ABI?
The toe, sir. Toe.
You have to measure the toe pressure, because
toe pressure index.
Yeah, many times toe vessels cannot be calcified.
Yes, sir.
What are the benefits of ABI? Why you are doing ABI?
Sir,
clinical use of ABI?
Sir, absent pulses can be held with the
clinical use of ABI. You are doing a ABI. Why you are doing ABI? Why you are doing ABI? Diagnostic. It is a diagnostic use.
Diagnostic.
Yeah, it has a follow-up use.
Follow-up. Yes, sir. Follow-up in.
To decide what type of management.
Yes, sir. Yes, sir.
Okay. Any other use of ABI other than atherosclerosis or the peripheral vascular disease or peripheral arterial disease? Suppose the patient has a varicose vein. Is there any role of measuring ABI?
No.
No. Whenever you are trying to use the compression bandage, you must try the ABI. The ABI is very low, people, that you should not go for the high grade of the compression. So it is better even for a varicose vein when you are deciding for a compression bandage.
Yes, sir.
Though it is not absolutely indicated, then you must do the ABI also. It will give you a guide, especially when it's the old man coming to you.
Yes, sir.
Okay. No, in this case, how did you measure the ABI? You have given the ABI value. How did you measure? How did you measure ABI? Angle brachial index in your patient, how did you measure? Yeah, how did you measure?
Sir, by measuring the ankle blood pressure, sir, using handheld.
That I know, whether you have measured by your hand or whether you have used a Doppler.
Sir, I used the handheld Doppler, sir.
Handheld Doppler, okay. Because you are, according to you, your peripheral pulses are not felt.
No, sir, absent, sir. Yes, sir. I used the Doppler.
Then how did you measure the angle brachial then?
Sir, placing the handheld probe in the posterior tibial and tying the cuff and ankle, sir. Lower limb pressure is measured, sir.
No. My question is, your dorsalis pedis, anterior tibial are not palpable.
Yes, sir.
In that case, when there is no flow, then how did you make? How did you make the pulse?
There was a monophasic flow, sir.
Okay. So you cannot do it by manual. You have to do
by, yes, sir. By Doppler. Okay. Yes, sir.
Okay, come back to a previous question. You had you asked for a Doppler.
Yes,
What all the points the radiologist has to give you, or what are we expect from the radiologist?
The site of a lesion, sir. Then flow, sir. Flow of the.
What's the flow?
Sir, arterial and venous flow. To see, sir.
Yes. What is maybe arterial flow?
So arterial flow is towards the probe.
Okay, I agree. That's always from the heart to the periphery. I agree. What is meant when you're asking for the arterial flow? What is meant by you?
So if there is complete occlusion, or there is some.
How the radiologist express you that's the flow, right? The flow.
Sir,
have you ever read a Doppler report?
Yes, sir. Monophasic or biphasic flow.
Yes, one is monophasic, then biphasic.
Monophasic, biphasic, or triphasic flow, sir. Normal is triphasic flow, sir.
Yeah, okay.
Yes, sir.
I'm not asking about different types of waves, but what is the velocity of the flow? What significance?
Velocity of the flow. Sir, yes, sir. If there is occlusion, proximally there will be more turbulence, sir. Turbulence can be expected, sir. Velocity will be increased proximal to occlusion.
In a stenosis?
Sir,
any difference in the velocity in obstruction and stenosis?
Sir, in a stenosis, velocity will be increased, sir. In stenosis, there will be turbulence, sir. In occlusion, there won't be turbulence, sir.
Yeah. Stenosis, there is increased velocity, and occlusion, there is no.
Yes, sir.
Okay.
Yes,
velocity
sir.
is decreased. Then, yes.
You can say there will be high-pitched continuous sounds you will be able to hear.
Yes, sir.
Yes, then.
Sir?
Then what are the other points?
And if there is multiple lesions in the blood vessel, sir, there is a single or multiple stenosis present or not.
Okay.
An anatomy of the vessel can be seen, sir.
It is Doppler, they can see the anatomy.
Vessel, sir, of the vessel, if there is any aneurysm or not, you can rule out, sir. Then
quicker, yeah, 10 more minutes more.
What is your differential diagnosis? Before coming to your diagnosis, what all have you ruled out?
Sir, atherosclerotic disease, sir.
You have ruled out.
What are other possibilities you consider? Other possibilities you consider? Your diagnosis POVD.
Yeah, what is your differential diagnosis? Apart from a provisional diagnosis, what is your differential diagnosis?
Yes, sir.
What have you ruled out?
Sir, atherosclerosis, sir.
You have ruled out atherosclerosis.
Yes, sir. No. I have to investigate further, sir, to rule out.
On the basis of a history and examination.
Yes, sir. History and examination.
What is your differential diagnosis?
Then fecal limb ischemia.
So what is Leriche syndrome?
Sir, Leriche syndrome is aortic occlusion, sir. So aortic occlusion, there will be bilateral gluteal claudication and absent lower limb pulses and impotence.
So you have ruled out. That means you have ruled out senile gangrene.
No.
No, yes.
I ruled out, sir. Femoral pulse is present, sir.
Okay. So what is the other differential diagnosis? What are the other diseases which you have ruled out based on solely on your history and diagnosis and your investigations to come down to a provisional diagnosis, which will be ultimately confirmed with their radiological diagnosis?
Okay, will you ask for angiogram this patient?
Yes, sir.
What are the indications of the angiogram?
Sir, angiogram, So if there is any occlusion in Doppler, we want to see angiogram.
What investigation will you do before asking for angiogram? What a single investigation?
So RFT.
RFT. If RFT is elevated, what will you do?
Angiogram
away,
and MR angiogram.
MR is completely safe in case of this thing. Is it absolutely safe?
Yes, sir.
Have you heard of gadolinium nephropathy?
Yes, sir.
Yes. Still you say it's safe? Okay, this create this 1.4. Straight away you refuse angiogram, or you do any steps to improve that renal status and do it?
Sir, what's it?
Creatinine is 1.4.
Yes, sir.
Slightly elevated.
Yes, sir.
Will you do angiogram or straight away reject it? Go for amputation.
So you can do angiogram, sir.
What all precaution will you do before doing angiogram with such a patient? A borderline renal insufficiency.
Sir, the anti-diabetic comobs we can to see, sir. We have to stop.
Stop. Which drug? Which all drugs is stop?
Metformin.
Okay, metformin stopped. Okay, that's one step. There are multiple steps.
Yes, sir.
What are TASC guidelines? What is the full form of TASC actually?
Transatlantic Inter-Society Consensus, sir.
What are the criteria for that?
It consists document. Completed. Document is the last word.
Yes, sir. Yes, sir. Document, sir.
When was it published?
Don't know.
In the year 2000.
What are the criteria of that task?
Yeah.
Or what are the factors on which the task is defined?
Sir, the extent of lesion, sir.
Yes. Length of
then,
lesion.
Length of the lesion, then single or multiple sites of lesion.
Okay.
Mainly based on this too, sir.
No.
Then
there are 3 grades: A, B, C.
Yes, sir. A, B, C, D.
The criteria are basically one is versus obstruction or stenosis.
Yes, sir. Obstruction or stenosis. Yes, sir.
Number of lesions.
Number of lesions. Then length of the lesion.
Length of lesions. These are 3 criteria.
Yes, sir.
Okay. So what are the 3 criteria?
So category A, it is stenosis less than or equal to 10 centimeters.
Okay. That's varies in very different. It just
yes,
varies.
I'm telling in my case. Yes, sir.
Yeah. Beyond this discussion, what's the importance of task?
Sir, to decide on the management, sir.
Yeah. How?
Sir, if length of the lesion is
can you broadly say task A is management, task B is this, task C is broadly? No, I'm not going to details of it.
Okay, sir.
That is beyond beyond this discussion.
Yes, sir. Task A is can be treated conservatively, sir.
This patient is a critical ischemia. Angio is done. I'm telling you that it's a task A lesion. Then immediately, what is your choice of management?
Sir, endarterial.
Yes, endovascular interventions.
Yes,
task A is basically endovascular, and task C is basically surgery. Task B depends on the lesion itself. Okay.
Yes, sir.
Then, what are the criteria by which? What are the steps to improve renal function? One is stop metformin. Hydrate the patient very well.
Hydrate the patient. Yes.
Yeah, before the procedure, during procedure, after the procedure. Then you can give N-acetylcysteine before the procedure. Yes. And if there's any active infection, you can control anti-inflammatory by antibiotics.
Yes, sir.
Still, if recheck the creatinine, if it becomes normal or reduced, you can go for a angiogram. Still, if it's not coming down, you have any other mode of angiogram in such a patient.
Carbon dioxide.
Yes, carbon dioxide angiogram, you can do it.
Yes,
okay, fine. What all points you look for in a case of angiogram?
The site of lesion, extent of the lesion, then collateral formation, sir. Then proximal running, distal runoff.
What's the importance of distal runoff?
So if there is distal runoff, bypass procedures can be considered, sir.
When will you consider?
If the distal runoff is absent, sir.
Runoff is absent, then how can you
Sir,
bypass?
no, sorry, sir. Distal runoff is present, bypass procedures can be done, sir.
What's the minimum runoff required to put a bypass? You need a runoff because then only blood can flow from the bypass. If there is no runoff, the blood will stop at that and it will thrombose. So what's the minimum distance required?
So 30.
At least 10 centimeters.
10 centimeters, yes, sir.
That's the essential minimum criteria to do a bypass or angioplasty. In both, whether interventional or endovascular or open surgery, at least 10 centimeters of distal vessel should be patent. Then only the bypass would work. Okay. What are the complications of these procedures?
Which one, sir?
So when you do endovascular or bypass, what will be the complications?
The graft failure, sir. In case of graft.
No.
Bypass graft.
That's a long time of immediate.
To maintain.
Sir, infection.
In the post-operative, what are the things you are going to look for then?
Sir,
that's routine for this particular surgery, endovascular surgery.
Sir, endograft infection.
You have done a bypass.
Yes, sir. Collapse.
What is compartment syndrome? What is compartment syndrome? What is reperfusion syndrome?
Sir, compartment syndrome is increased intra-compartment pressure, which leads to.
So, which compartment will be affected first? In the limb ischemia, you are doing the which compartment you are expecting the most first sign to develop? Well, first, which among the nerve, vein, artery, muscle, which one will affect first?
No, sir.
What is the first nerve to be affected? What is the nerve of the anterior compartment?
And, sir?
Nerve of the anterior compartment. Commonest compartment. So what is the nerve there? So when peripheral vascular or varicose vein, you must read the compartments. What are the muscles? What is the artery there?
Yes, sir.
So deep peroneal nerve.
Yes, sir.
So what will be the complication of the deep peroneal nerve involvement?
No palsy.
What is the first? Which that nerve palsy resulting in what is the first neurological sign patient will have?
Pain. No. Pain, pallor.
No.
Pain will be present, sir. Paresthesia.
Where will be the paresthesia?
Sir.
So first interweb phase, then patient will have the foot drop. So these are the neurological symptoms. So these are. So you must know the sequence of events, how it is taking place in the compartment syndrome. And once you see for the compartment syndrome, to prevent that, what do you do?
Sir, distal fasciectomy.
What fasciectomy will do? On one side, both the side.
Sir, one side.
All the compartment. No, you must do both the side. You must through that side. You must open all the compartments you need to open.
Yes, sir.
So one is that. Second one is so you must also know about the reperfusion syndrome. So especially the limb is a little thrombus. You are doing surgery after 4 or 5 days. Then definitely there will be a problem with the reperfusion also.
Yes, sir.
Okay.
What are the 6 P's for acute arterial ischemia signs?
Sir, pain, pallor, pulselessness, paresthesia, then
Poikilothermia. What is that?
Poikilothermia. What is poikilothermia?
Sir, decreased cold limbs, sir. Decrease in temperature.
Persistent cold.
One more point is left. You said 5. Paralysis.
Yes, sir. Yes, sir.
This is your patient with probably a Buzzard's disease.
Yes, sir.
So what are the various options which are there for the Buzzard's disease?
Sir, first lifestyle modification.
Good.
Stop smoking. Then symptomatic relief, sir. Analgesics can be used for pain relief.
Analgesics.
Sir. Then antiplatelet drugs can be given, sir. Then exercise can be done to improve the collateral formation.
What is the role of heparin, unfractioned heparin?
Sir, role of heparin in Buerger's disease, sir. Sir?
What is the role of anticoagulant therapy? I'll be more precise.
Sir. Sir, to prevent progression of the disease.
Which drug can be given for long term for prevention? That's an
Aspirin.
Therapy.
Aspirin can be given, sir.
Or warfarin.
Sir, aspirin, sir.
And what is the role of unfractioned heparin?
Why are you giving aspirin to this patient?
Sir, to prevent platelet aggregations.
Okay, then?
What is the role of pentoxifylline?
Pentoxifylline, it also prevents platelet aggregation, sir, and causes vasodilatation, sir. Sir, it is non-selective phosphodiesterase inhibitors, sir.
How it acts? It alters the shape of RBCs.
Yes, sir. It alters the shape of RBCs, sir.
What are the other options apart from the medical treatment?
Sir, there are endovascular procedures, revascularization procedures, sir. Then bypass.
Is it possible to carry out the revascularization procedure?
No, sir. Only in large vessels can be done, sir.
I'm talking about the Buzzard's disease. Okay.
Yes, sir. Bypass surgeries, then lumbar sympathectomy can be done.
If you have to do a lumbar sympathectomy for a patient with a Buzzard's disease, what are the indications?
Sir, ankle brachial pressure index should be greater than 0.3. Sir. Then that's, sir.
Other indications?
Sir, there should be no neuropathy. Then coma should not be there, sir. Then severe limb ischemia should not be present, sir.
So are you going to do it for the intermittent claudication or the rest pain?
Rest pain, sir. It has no effect on intermittent claudication, sir.
Only for the rest pain, if it is there. Then
yes, sir.
Will you do a unilateral sympathectomy or bilateral sympathectomy?
Unilateral, sir.
If you want to be really effective, it has to be bilateral.
Okay.
But if you do the bilateral, then you know what are the various ganglions which are removed in that?
Yes, sir. L2, L3, and L4, sir.
Okay. So if you have to do the bilateral one,
why not L1?
Sir, L1, if it is done, there will be bilateral L1 retrograde ejaculation can come cause, sir. So it should not be done, sir.
L1 has to be preserved at least on one side.
Yes, sir.
Okay. What is the principle of lumbar sympathectomy?
Sir, what?
What is principles of lumbar sympathectomy?
Principles of? Sir, I'm asking the procedures. Procedures, sir.
Principles.
Sir,
It
principal,
increases the blood
sir,
flow.
it increases the blood flow and sir, it relieves vasospasm, sir.
Reduces the ischemic rest pain.
Yes, sir. It reduces the rest pain and perfusion. It prevents level of. It preserves amputations, sir. It prevents amputations. Then non-healing ulcer can be. It can be healed. Non-healing ulcer, sir.
For the anatomical structures, we can mistake it as a sympathetic trunk.
Sir, ureter, IV ureter, inferior vena cava.
No.
Mistaken.
So,
ureter.
Genitofemoral nerve.
Any
Yes, sir,
nerve? Any nerve?
Yes, sir. Genitofemoral nerve, sir.
Sympathetic chain.
Yes, sir. Sympathetic chain.
Sauce and sauce
Sir?
minor.
Yes,
Sauce
sir.
minor.
Yes, sir.
When does amputation
What
become?
are indication?
When does amputation becomes an option? The only option left. When does amputation becomes the only option? Because you said the word amputation right now.
Yes, sir.
When it is
Sir,
the only least desirable option left.
What
Least
are indications for
desirable.
Sir, if there is gangrene with a well demarcated line, then minor amputations can be done, sir. And if any of the surgeries, endo procedures or a bypass graft, it is failed, then amputations can be considered, sir.
Whenever there is a gangrene is there.
Line of demarcation.
Sir? Sir, I
What is
couldn't hear, sir.
significance of line of demarcation?
Sir, line of demarcation signifies that the proximal tissues are well perfused. So doing an amputation prevents the progress of the disease.
Which bony disease is related for amputation in such a case?
Sir, which bone?
Yeah. Bony disease. Disease of
Yes, sir.
bone.
Osteomyelitis. Yes, sir.
How will you know that your sympathectomy is effective? You operated this patient today morning.
Yes, sir.
And you go for the rounds in the evening.
Yes, sir.
How will you know that you have done a good sympathectomy?
Pain relief.
For the pain, you are giving the patient analgesics. No? Always you will give the patient analgesics.
Yes, sir.
For the pain.
The perfusion of the limb can be improved, sir.
Check for the temperature of the limb. No?
Yes, sir. Yes, sir. There will be increase in temperature. Yes.
It will increase in the temperature.
Temperature. Yes, sir.
You know, there are several tests which are there, which are usually not done nowadays, like the Brown's vasomotor index, which is there.
Yes, sir.
Or people doing the Burz's test. For the Burz's test is not good for the Indian people.
Yes, sir.
Disappearing pulse. Okay, all these are making the patient unnecessarily tiring by checking for the disappearing pulse. Omen sign in the case of the DVT. All these, in fact, are not. You should know that all these tests are there, but
yes,
you should not demonstrate all those tests. Okay.
Yes, sir.
Okay, because all these are not giving you and unnecessarily making the patient irritated by carrying out that.
Yes, sir.
And you know, whenever we are talking about the task classification or the system which is there, you have to always see that whether it is there are three types of tasks which are there, whether you are dealing with the autofemoral component,
yes, sir.
or you are dealing with a femoral component or infrapopliteal component.
Yes, sir.
So task is different for all the three.
Yes, sir.
So like in your patient, it will be like a femoral popliteal.
Yes, sir.
So it will depend upon that which type of the disease you are dealing, and then you decide about the task of that.
Yes, sir.
And then there are few other types of the treatment which are there. Historically, they have been described, like carrying out the Eliza Rao technique. You know what is Eliza Rao technique for the?
Yes, sir. A part of a bone is cut and external fixator is applied, and the osteogenesis will help in healing. Sir. That is Eliza Rao technique.
It's called a distraction type of the osteogenesis.
Yes, sir. Yes, sir.
Okay. So then people, they made the AV fistulas also for the Bursary, but all those are not very. And then endovascular treatment is being tried for that you
Yes,
can
sir.
go for a retrograde treatment for that as the endovascular treatment. And then the stem cell, which is there. Okay, stem cell has
Yes,
come
sir.
in a big way, but
Yes,
though
sir.
it is not very successful, but it has come in a big way for the
Yes, sir.
Bursar's disease. So these are the other treatments which are available for the Bursar's disease.
Yes, sir.
The most important is smoking. Your patient must stop the smoking.
Smoking. Yes,
Whatever
sir.
you do for these patients, if the patient doesn't stop the smoking, he is going to come back to again. Okay.
Yes, sir.
Preeti, two quick questions. To diagnose TAO, you have got all clinical criteria, like the Shinoy criteria. So angiogram is very important in diagnosing an atherosclerotic disease or differentiating an atherosclerotic disease from TAO. What are the angiographic findings which would point out that this is mostly a Bursar's disease? Any classical findings which are described?
Sir, corkscrew collaterals are found in TAO, sir. Bursar's disease, sir.
Yeah, one more. Just discussed already. The nature of involvement in the vessel, along the vessels.
Yes, sir. Yes, sir. Segmental lesions will be present
So
in
segmental involvement and corpus collaterals tell that it is. So why do you think that? Do you think that it's easy to treat a TAO or an atherosclerotic proximal arterial disease in critical limb ischemia, which is easier to treat? With regard to the results, I'm asking.
Atherosclerotic.
Why? Why is TAO so resistant to treatment? Why are the results so inferior?
So due to segmental involvement.
Yeah, because two reasons. One is the distal runoff is very poor. And two, the pathophysiology is that the inflammatory infiltrate, the thrombi, you have described that the Doppler contained thrombi in both SFA and popliteal arteries. So the thrombosis contains the acute phase of TAO has got, there are two phases now in TAO. The acute inflammatory phase where the thrombus is infiltrated by polymorphonuclear leukocytes. And then it spreads along the vessel wall and inside severe fibrosis. It's this fibrosis of the vessel wall which you palpate and feel in TAO that makes it resistant to treatment. You do an endovascular angioplasty, it goes for a recoil again. You do a bypass, there is no distal runoff. So, so as Dr. Ajay Khanna rightly described, first step will be relief of pain by your pain. You have heard about WHO step ladder for pain?
No, sir.
How do you control pain in this patient?
Sir,
suppose you cannot, the gangrene or patient cannot sleep and your pain is not resolving. What are the options? So you need to get relief of pain. Two, you need to heal the patient. He is an active.
Sir, first analgesics and aspirin and NSAIDs can be given, sir.
Yeah.
Then sedative opioids can be given, sir. If you're not relieved, opioids can be given, sir. Tramadol can be given, sir.
Yeah.
After that, then morphine can be given, sir. If tramadol is not responding.
Acetaminophen, NSAIDs. If creat is fine. Mild opioids like tramadol, go up to narcotics. Then will be a regional analgesia, like nerve block to bridge our pain in a phase where you can do something, or an epidural analgesia, because rest pain, control of pain is very important, extremely important in TAO patients. Because once you give an epidural shot, the patient goes for sleep for 48 hours. Would not have slept for hours. That's very important. Second is planning and intervention. So as Dr. Ajay Khanna described, very often endovascular and bypass options are not feasible. But you do an amputation of a demarcated toe, again it goes for gangrene in TAO because there is no collateralization good enough. So
Yes, sir.
your options are very limited. The probable options are prostaglandins, stem cells, and these are the only options which are PG even only options we tried, but results are not standing, long standing, and stopping of smoking is the most important. Thank you. Good luck.
Thank you.
The permission of the faculty. Preeti, do you have any questions or doubts to be clarified?
No, sir.
Okay.
Just say one last thing.
Please,
one
sir.
last thing.
Please,
One last thing I'll like to say, sir. Suppose we don't have an angiogram available. We are in a periphery center.
Yes, sir.
Will an X-ray be helpful for the diagnosis of peripheral vascular disease? A simple X-ray.
Yes, sir. Peripheral vascular disease, sir.
Yeah, to help for in the diagnosis of a peripheral vascular disease.
Calcifications can be seen in through.
Yes, and what is that known as? What is that degenerations known as? Monickberg's degeneration.
Yes, sir. Yes, sir. Monickberg degeneration. Yes.
There are many centers where angiogram is not available still in India. So
yes, sir. Yes, sir. Thank you.
Thank you.
Kanna sir, anything else, sir? Can we call a close, sir?
Yeah, please. I think we can close now.
Sir, thank you, sir.
Vimal sir, Nishant sir, Kumar sir.
Nothing else. Discussion was okay, but some comments to the candidate Preeti. You should be a little more composed, and you should be cool in the exam. The examiners are not there to hurt you. We are just trying to help you. So in the starting itself, you feel that you lost the exam. Like you'll be very tensed. That this is not an exam. It's only a trial. It's only a trial for your final exam. So when you are facing such chances, you should be a little more cool, a little more composed, and then that will make a huge difference. The starting itself, almost you said that it's almost some lost gains in that. Nothing like that. Examinations are chances, and the examiners are there to help you. And never take it. It's only an experience for your future life. That's all.
Yes, sir.
Okay. All the best.
Yes, sir. Thank you.
Thank you, sir. Thank you, Ishan sir, Nishikant sir, Kumar sir, Vimal sir. I think Padma ma'am has left. Kanna sir, JLL sir, I think Karnakaran sir, Hitesh sir already there. Rajiv sir, and other faculty who have joined us, thank you very much. We look forward for meeting again in the next Friday. Good night, everyone.
Good night, sir.
Thank you.
Thank you.